YouTube link, right?
Yes.
Yeah. So we'll be Rakesh sir will be able to have. We have 100 Zoom, so we'll have up to 80 will admit, and rest will go to YouTube. The YouTube link is on. Direct YouTube link.
So we are live on YouTube.
Yeah, yeah, that's good, Varish.
Yeah, you're live now, Sheikh.
Yeah, yeah, good. Yeah. Amish bhai, we can start 8:30.
Okay. So it's 8:30. Hello, good evening. Welcome everybody to a wonderful CME, which is going to be a back to basics for all of us, right from all the trainees to the consultants. And this was a theme from Mumbai Intensive Pediatric Care chapter of. Yeah, I'm talking. Can you hear me?
Yes, sir, we can hear you.
Yeah, sorry. So this was a theme from Intensive Care chapter of Mumbai IAP to have a CME, quarterly CME. And this time the plan is on fluid and sodium. Today is on fluid and tomorrow is sodium. We have an excellent people to chair and to give us a talk. And before we go to the plan of the CME, please may I request everybody to give a minute of silence in memory of colleague IAP Vice President, Major Professor K. Nagarju. Okay, thank you everybody. I forgot to mention that if some of you don't know, Professor is a IAP South Zone Vice President and we lost him recently because of COVID-19. Having said that, please may I request current chairperson, Mr. Dhiren, to please say a few words. Dhiren.
Yeah, thank you, Amish, for making me part of this CME, and thanks for breaking the COVID scenario. Everybody is fed up with the COVID, and we can every 6 months we land up in post-COVID era. So I again congratulate you and the IAP Intensive Care chapter of Mumbai for initiating the series on basics. You know, basics have always been very interesting and they are actually backbone of medical specialty. Probably the most interesting part of any branch, any specialty is to understand basics again and again. And in fact, one point I want to make here that COVID has actually broken the compartment between adult and pediatric. Today we have chosen the topic of fluid, and it's very interesting to understand that adult patients do not tolerate fluid at all. The liberty which we have in giving fluid to pediatric patients, we don't have liberty in adult patients. And we all know that past two, you can say decade belong to aggressive treatment of hypovolemia, but this decade belongs to de-resuscitation, means less fluid and take out the fluid which we have given over past 24, 36 Sure. So I don't want to waste the time. Again, I congratulate the Mumbai team, especially Dr. Padmanand, Dr. Amish, Dr. Lakshmi, and my friend Dr. Sheikh. Thank you very much.
Thank you, sir. Please may I request Dr. Mahesh to kindly give us few words.
Thank you, Dr. Amish, for giving this opportunity. I'm really delighted and thankful to the Bombay branch. Actually, it's my own branch. I should not say Bombay branch. It's my own branch. And every new body brings a lot of dynamism and activities to the chapter. And the present body, I'm really excited to see and expect really huge academic program coming in the future. And as Dhiren rightly said, we are full of COVID and we want to get slightly away from it. And you have chosen the right apt topic to start with. The less is a more is a concept that we are going for, and I'm really expecting a lot from this CME. I'm expecting from the future CME again. I thought you will be going it at least bi-monthly, once in 2 months, or maybe once in a month. Once in 3 months is too much of waiting. You should seriously consider whether we could go it maybe slightly more frequently so that we could cover more and more. And the kind of faculty you have chosen is absolutely wonderful. It's really going to be a good treat. Thank you very much for giving such good treats and keep giving it again and again. And we do expect lot of good academic activities are coming here with Parmanand, Amish Bora, Lakshmi, and Minaj being at the helm of the story. Thank you very much. We all want to hear a lot from you. Thank you again. Thank you very much. And I wish all my great kind of wishes for the success of this ongoing and upcoming CAVs. Thank you.
Okay. Thank you all of you. And with that, without taking much of the time, I think this is a CME. We do not, we want to start with the main thing which we have come here for. And with that, I would like to introduce our chairperson for this CME, Dr. Jayashree. All of us know Madam very well. And Madam is the professor and chair of emergency Professor and Chair, Chief of Emergency and Intensive Care Unit at Pediatric Center at PGI Chandigarh. She's also a chairperson for the COVID Management Committee. We know Madam is very well reputed and is very frontier in publications, research, and always a mentor for all of us. And we know that she is very well interested in fluids, ARDS, electrolytes, DKA. And with that, I would ask Madam to please take the process forward and introduce our speaker, Dr. Andrew Durwood, please.
Good evening, everybody. And thanks a lot, Amish, Dhiren, Mahesh, and the Mumbai Intensive Care Chapter for having thought about this particular CME, where we would like to take the participants back to basics, which is a very important thing, as has already been alluded to. Fluid therapy is probably one of the simplistic interventions that we do in hospitalized children. We consider it like that it's a very simple intervention that we have been doing in hospitalized children for decades. But however, the age-old convention, traditions of fluid therapy has been challenged, questioned, debated, and deliberated over the years. And several interesting facts and facets have come to the fore as far as fluid therapy is concerned. And I know that Dr. Andrew is one of the pioneering person who has done a lot of work on fluid therapy. And therefore, he's the most appropriate person to talk on this. And it gives me immense pleasure to introduce him to the participants as well as the other panelists. Dr. Andrew Durwood, he did his medical and pediatric specialty in Cape Town, South Africa. Subsequently, his fellowship in critical care at Sick Kids Toronto. He has intensive care work experience of 25 years, of which he has spent 21 years in UK at Guy's in St. Thomas. And currently he is working in the cardiac intensive care unit at Doha, Qatar, where he is director of the ECMO program. He has special interest in fluid and acid base, and he has been one of the key members of the NICE UK Guideline Committee, the expert committee which constituted guidelines for the management of diabetic ketoacidosis. So as I said, he's the most appropriate person to take us through the fluid therapy and many of the interesting facets that have come to fore over the last 2 decades, and has in fact challenged whatever we were doing and considering it to be a very simplistic kind of intervention in hospitalized children. without much ado, over to you, Andrew. We are eagerly waiting to listen to you. Take us through this interesting topic.
Thank you very, very much for that introduction, and also for inviting me to speak to you again. So if I can share my screen, can you see my talk?
Yeah, it's visible.
Yes, Andrew.
You
Yeah.
could.
Great.
Yeah.
I don't know, how do I get this done? Minimize. There we go. Perfect. So thank you very much. And it's a great honor really to speak to all of you again. I was always interested in fluid therapy because when I was training, it was said to be simple. Everyone knew the formulas, everyone knew how to prescribe fluid, but we actually learned that there were a lot of wrongs in what we were taught. So my talk is really a historical adventure of how things got to where they were, which I think is the only way you can actually learn medicine. And I had some very good trainees with me, and I will share with you some of the nuggets of the journey in terms of how we are and where we are. So just starting off, this remarkable slide, this is a goat from Europe climbing up the wall of this cliff, this enormously high cliff. These goats climb up here every single day with all their children just to lick the sodium off the wall. They have this absolute desire for sodium. It's part of their normal life. So they actually risk their life and death for salt. Now, we as humans, we don't have to take the risks and climb up there because we are presented in our entire life by different fluid concoctions as we go from childhood over here where we drink milk through adulthood, and then perhaps in old age when we drink a bottle of Ensure. The key thing here is when we are sick and we need intravenous fluids, things change a lot and we have to predict which fluid we will use and why. And this is really what got me talking about, because when I started pediatrics 15, 20 years ago, we were using 5% dextrose, 0.18% saline, and we were seeing patients die as a consequence of the fluid we were using. This is a case report from Archives in Manchester, UK. Baby comes in with a bit of dehydration and diarrhea, normal sodium, gets the routine fluid of the day, 12 hours later has a seizure, dies from cerebral edema with a plasma sodium of 120. And at that time, we knew this Alan Ariev, who is the guru of sodium disorders, did experiments in animals. Here's brain water. And you can see patients with hyponatremia have a big swollen brain. And these are the people who die. So clearly something was wrong in what we were being taught. And it took half of my career to work with other people to ban this solution in UK. And you can see here, finally in 2007, there was a patient safety alert banning the use of hypotonic fluids in UK because of the dangers they pose. So the question is, how did we get here? And how is it possible that we got things so wrong? And it really comes down to this seminal paper in 1957. This is Holliday. This is Seeger. Holliday actually died recently. I wrote letters to him asking why he keeps on persevering with this formula. He wrote me very nice letters back. So he really is quite a gentleman. But nevertheless, this formula that you all read in your textbook has to come from somewhere. And so in my endeavors with some of my students, we went and found every article ever written about pediatric fluid maintenance from the history of the library at King's Cross in England. And we found out the truth behind where this came from and how it came from. So I'm going to actually talk about that. So we're going to go down the history lane, and we'll find here in 1932, the very first time an intravenous infusion was given to a patient recorded in medical history. And I think this is such an elegant paragraph that I have to explain it. So there's a patient dying from cholera. This doctor, Dr. Lata, puts a catheter in the basilic vein and starts giving volume. No one had ever done this before, gives volume. And he writes here, still persevering, I thought she began to breathe less laboriously. Soon, the sharpened features and sunken eye, fallen jaw, pale and cold, bearing the manifest impress of death's signet, began to glow with returning animation. The pulse, which had long ceased, returned to the wrist, at first small and then quick. By degrees, it became more and more distinct, fuller, slower, and firmer. And in the short space of half an hour, when 6 pints had been injected, she expressed in a firm voice that she was free from all the uneasiness and actually became jocular. So this is the most remarkable bit of prose. This is how they used to write papers historically. And I really think they should keep writing like this because it's wonderful to read this. So this was amazing. The problem is no one actually ever followed that up. And so we go from 1830s to 1879. Here, the Blackfan, who was the same person with Blackfan diamond syndrome, started using peritoneal fluid for gastroenteritis. And then at the turn of the century, people started using the word homeostasis, water homeostasis. This was the real concept. But at this time, of course, acid base wasn't invented. You couldn't measure electrolytes. There was no idea that it was ICF or ECF. But they started to realize that heat production and body surface area are related. So we move on to 1916, where Dubois and Dubois were two people. They realized that body surface area is coupled to height. And you can see here a surface of the cube. If a cell is a circle, it's a sphere, they could actually work out the dimensions of this by using body surface area. And they worked out crudely basal metabolic rate, how much energy you burn based on your weight in kilos. And this is the famous Harrison-Benedict equation from 1919, which still is in every single textbook in terms of energy expenditure that you'll get. But you will note that they only had adults, patients of 35 kilos up to 95. So they understood that somehow surface area is related to metabolic rate. And today, this is called Kleiber's law. We know this is absolutely true. This is metabolic rate, this is mass, and you can go all the way up to the elephant and all the way down to microcellular organism. There is a strong relationship. So they were clearly onto something there, but still had no clue about IV fluid. And you can actually see here that in 1923, cholera was still a problem. People were getting surgery. And you can see here that one of these chaps was quite upset about intravenous fluids being regarded as a shun thing in the day. He said, personally, we believe surgeons have simply drifted into employing salt solutions by rectum without giving any serious consideration to what they were doing. And such is our excuse for this paper. So the intravenous fluids came because some clinician was tired of watching surgeons putting rectal catheters up people, giving them fluid that way. So this was quite important. And around this time, actually, James Gamble was a famous biochemist. This guy started doing work with fasting, and he was actually the guy that suggested ketosis is a cure for seizures. So the whole idea that you starve patients and make ketones for epilepsy came out of his work. But at this time, you still didn't have electrolyte measurements. Acid base had just been born. The Hasselbalch theory had just come out. Now, something really important happened in 1933, and this is Homer Smith, who is really a nephrologist, who did the most important paper in the entire history of fluid balance that was completely ignored at the time because he was agnostic. And he did not believe in religion, and he believed that animals were the same as fishes, and whatever the cell you are, it doesn't matter. And so his work never really made it into mainstream literature. Now, he did this amazing experiment. He gave 1 liter of saline to volunteers, and he gave 1 liter of dextrose water. And he noted that if you see urine output here, you got this huge urine diuresis when you gave dextrose water, but nothing actually happened when you gave saline. And this is really the crux of fluids, is because saline is obviously isotonic and it won't change osmolality, so you won't get a response. Whereas dextrose water will create here, you can see plasma-specific gravity, which is osmolality. It drops the sodium, drops the osmolality, and the brain, in an absolute crisis to defend itself from cerebral edema, will pee out this huge amount and then cause diuresis. So he was the first person to say saline and dextrose are very different. Let's look at that. The problem was he was ignored way back in 1933, and this chapter was disappeared from literature. I had to actually struggle to find the original paper. Now, at the time, some really strange things started happening because people were interested in insensible weight loss, how much fluid you lose. And they did the most bizarre experiments. So this is 1933. one of us recorded many observations that at the onset of fever produced by the administration of cocaine, there is concentration of the blood. So these people were making volunteers sweat to measure their insensible losses by filling them up with cocaine. So quite remarkable. You wouldn't get away with this today, but they actually worked out fluid losses. And if you look here in 1956, this is the original reference for body squared fluid loss of 330 mils per meter squared. This is where it comes from. This is written in every single textbook. It is a horrific experiment. They got anuric people in renal failure because they knew that the kidneys wouldn't be doing anything, and they sent them in a boat in the sun until they dehydrated, brought them back, measured their weight, and said that's how much fluid you use because that's how much weight you lose. So this is actually in every single textbook of medicine with no validation at all, but it appears there from 1956, and I think people will still quote this today. Following that, there were bizarre experiments in diabetes, in DKA. These are the experiments of Ashley, which I got quite interested in doing work on DKA, where they took insulin-dependent teenagers, this is a 23-year-old, and deprived them of all their insulin until they basically went into a coma. And you can see the comment says here, furthermore, it was evident to both the subject and to us that the discomfort produced by the curtailment of water led him to omit many of his accustomed activities. For example, we noted that he was lying on his bed the greater part of the day, and sometimes they actually even let his wife and child in. I mean, this was remarkable. They pushed this person into DKA to get him to be dehydrated to work out fluid losses. So things you did in 1940, you wouldn't be able to do today. This is the table showing they did it a number of times. And you can see here, this is how much weight he lost when they actually did these experiments to him. So these were called the metabolic experiments of the time. Now we moved to 1940 because something really important happened in 1940. They started measuring sodium and chloride. And the thing here is that you invented this machine called a flame photometer. So if you took serum and you spun it down to get plasma, and you dehydrated the plasma and you burnt it in a machine to produce a flame, the intensity of the flame would give you the concentration of the electrolyte. So for the first time ever, in 1940, they could measure sodium and they could measure chloride. They could measure potassium by this machine called a flame photometer. And this holds today as one of the most accurate ways of measuring sodium. So they started looking at the different distributions. There was more, for example, sodium in the ECF than the ICF. And you can see here a drawing from 1940 with a child, and then this is an adult. And they noted then the differences. The ECF was a little bit bigger in children compared to adults. And so here we have the partitioning of ECF and ICF, and probably a really important thing for me, because I do a lot about acid base, was they recognized how important chloride was. So it says here, chloride was of course understood as the dominant anion of plasma and thus co-responsible for the osmotic defense of volume. Also in the language of acids and bases, anions such as chloride were the acids, and thus chloride was the main acid of the blood. And we completely ignored that for the next 40 years until today. We started questioning chloride and what it means. And I'll talk a little bit about that later. So quite interesting how we keep learning the lessons and then completely forgetting them. Now in 1940, Gamble, who was a pediatric nephrologist, actually managed to measure ECF volume. And so they used inulin and they could measure ECF volume, which is by chloride clearance really. And so he recognized this concept of extracellular volume. This is the internal volume that sustains life. And you can see here, once again, these experiments where they took patients, they dehydrated them until they were frazzled. You can see here they lost something like 65 to 60 kilos. They would lose 5 kilos of weight by basically dehydrating half to death. And then they looked at chloride changes and they could work out ECF and ICF. So this is quite a remarkable chapter in the 1940s. Until this chap came along. So this was a surgeon, and surgeons always have to complicate things. This was a guy called Collar, and Collar was a real pain because he believed that if you give patients salt, so sodium intolerance, everyone will get sick and everyone will die. And it says here, it is felt that no isotonic solution or ringer solution should ever be given during the day of operation or the subsequent 2 days. So in his era, these patients all got dextrose water. They got flooded to death. And if you actually look at his papers, these patients became grossly edematous, hyponatremic. But to the day he died, he was the person that said sodium is dangerous, sodium is poisonous, we should not give sodium. And unfortunately, this was the error when I came in pediatrics. This mantra was really spoken day after day. And look at all his publications. He was incredibly powerful and he owned many of the journals. And so the dogma started that sodium is bad for you. Now, 1946, actually, because they had worked out sodium balance to some degree, they had worked out ECF. This is when Holiday came with the pediatric formula where he didn't like surface area because he said surface area is difficult to measure. I'm just going to use weight in kilograms. And so they started publishing how much fluid babies lose, how much fluids you need. And they started referencing all of these papers here as their reference for this. And this is the main textbook of the time. This is the seminal paper by Gamble and Pratt, which said insensible losses in children are 100 per kilo per day, broken up by stool losses, by urine losses, by skin and lungs. This is the sodium amount you need. So me and my colleague Dan Taylor, we went and found every reference that they spoke about. And it actually turns out that there were no references at all that they based this on. So for example, if we follow the reference in this article about stool, we will see a line that says in the reference of the paper that references the stool, it says there are no generally available data of fecal water loss in preterm infants. Losses in full-term infants are said to be about 10 mils per kilo daily. Reference number 1. So we found reference number 1. Reference number 1 is called the concentration of urine solutes by young infants. And reference number 1 has no mention at all of the word stool in the entire paper. So I got concerned here that we just have this sort of data thrown at us, fabricated, and yet there is no science behind it. And it is actually true when we looked at all the data, we couldn't find any. So moving on, before actually the formula of Holiday over here, we had one very smart person, and this was Darrows. Darrows was really a bright pediatrician who was involved a lot with dehydration, and he was the first person that gave 20 mils per kilo of isotonic saline to children to treat the ECF. So this is the first time we actually have the words restore the ECF, give 20 mils per kilo of saline. The problem was his formulas were quite confusing. He had a lot of things about insensible loss, surface area. No one really knew what to do with it but him. And so we got these graphs that appeared. This actually graph appeared in Lancet, which actually said this is sodium concentration in IV fluids. This is liters per day. And it says here, basically everybody here who gets a little bit of sodium in a bag of saline is going to be toxic. So it says here, sodium retention and edema formation. So we were really poisoned back at this time that you can't use sodium, you have to give water. And this bunch of people here, which is Wallace, Seegers, Gamble, Holiday, they were part of what was called the Boston Salt and Water Club. They met socially, they discussed their ideas, and they published in the literature because they were incredibly powerful. And actually many papers that they published became mainstream practice around the world. And if you were opposing their view, you couldn't get published. So Holiday here went on to publish the famous paper that we use for reference in fluid balance in children. So this is it. We go and get the paper. And I read this paper and I was actually quite horrified because if you see, there were 25 infants, 25 children, 8 adults. They brought them into a hospital. They gave them 1 mil per kilo per calorie of fluid. They used kilogram instead of body surface area. And they based their idea on basal metabolic rate from a guy called Talbot. So if you go and find the original paper from Talbot, who looks at body surface area and metabolic rate, you will see this is from children all the way up to 70 kilos. And if you actually look here for the children, you will find that there are only 7 patients. So the entire history of basal metabolic rate in children is based on 7 children from 1940 that became dogma. And that is the line here. So this basal metabolic line, this is the original graph from Holliday and Seeger's paper. This line here is measured from 7 children, remarkably. Now, it turns out he was actually quite right. This is pretty close to this when you do it today. But what Holliday did is he said anything under 10 kilograms, we're going to give you 100% fluid. And then as you get bigger, we'll give you the balance between your home amount. So this is normal patients, and this is basal metabolic rate, and we'll just draw the line in the middle. There is absolutely no data backing this up. In fact, they actually say it here, computed need for average hospital patient. There was no work done to actually show what this was, but this just became the norm. So all babies were getting 100 per kilo per day, whether they needed it or not. And this actually created a massive fallacy. So if you actually look at the original paper, all they did is they gave 100 per kilo per day to these infants and children. So this is infants, this is children. And they looked at how much urine they make. If they made dilute urine, they put them in this group, said the specific gravity of urine was low. And if they made concentrated urine, they said you don't have enough fluid. And they said, well, actually 70% of people seem to be okay when we give this. So that's the fluid of the day, and hence the formulas that we see. And when they looked at the energy expenditure, how much milk you take and how much sodium and chloride you take, they took human milk, which was 1 millimole per kilo. They took cow's milk, which was 3 millimoles per kilo. And then they sucked their thumb and they said, we'll take somewhere between 2 and 3 as the normal sodium requirement. There is zero data validating these formulas in the entire history of medicine and still today. So I will show you some data later on this. So they concluded that really, if you're going to give intravenous fluids, you're going to give just a little bit of sodium, which is 0.18%, give 4% dextrose for the calories, put that in an IV fluid, and that's your maintenance fluid. And of course, today we know this is dangerous because this is hypotonic fluid. And this is the original formula that we see in every textbook. And by the way, this is in pediatric textbooks, anesthesia textbooks, PRCU books, PALS courses, APPLES courses. Everywhere you go, this went unquestioned for years until we came around. Now, you will notice here that if you look at the fluid requirements in terms of calories by body surface area, which is here, this is the correct way of doing it, not by this just everybody gets 100 mils per kilo. You will see that a 10 kilogram patient will get 40% too much fluid if you use the fluid in the textbook. And this is why if you give 0.18% dextrose to children who are 10 kilograms, who come to hospital for diarrhea, you're giving them way too much fluid and they will get hyponatremia and seizures and they may die from that. So this is a major, major flaw in what we were taught because people forgot to look at surface area. And of course, everybody here knows today ADH is there, and ADH is released from hypertension, stress, pain, fever. And if you have ADH on board, you cannot excrete urine. So way back in UK, this is 20 years ago, one of my fellows published this paper looking at broncholytics in England, in London, and they were all on 0.18% saline. And there you go, they all had hyponatremia, a lot of patients, extreme hyponatremia and seizures. So we needed to basically stamp this out. At the same time, Des Bone in Toronto found the same thing in Canada. Alan Arieff found the same thing in America. And we had this shocking bunch of deaths of children in Ireland that all went to die from hyponatremia, which was partly covered up by the hospitals. It went into the newspapers. And today this is still going on because the doctors who were prescribing the maintenance fluid of the day were thought to be guilty of murder because they gave fluids that basically killed the children, but it was in the textbooks of the day. So quite shocking. This is 2009, a competition in America, where this woman was asked to drink 7 liters of water and hold your Wii for as long as you can. And the person who can hold their Wii for longest will get a Nintendo Wii. So she was very stressed, had high ADH. She drank 7 liters of water and died from acute hyponatremia from drinking 7 liters of water. So clearly at that time, we said, okay, this is me. And then I got really irate and we started bombarding the journals with, we cannot be on these maintenance fluids because they're damaging. Other people started saying hospital-acquired hyponatremia is bad. And this is Moritz who's a real guru of sodium, and we basically started moving forward. Now, I remember writing to Holiday, and he actually said, if you give isotonic saline for 6 to 12 hours to children with heart disease or renal disease, they will get this massive sodium load. This is what he said at the time when I wrote to him. And so we wrote back saying, this is actually rubbish. We have children in our CICU. We use normal saline in all of them, and we have kids on bypass, and their sodiums are fine. So you need to retract this in terms of what you said. So I will just now move to a little bit about actually what the theories are today, because we've discovered a lot of things. Now, back here in 1957, this is a chap called Edelman. He discovered that the serum sodium concentration was proportional to the sodium and potassium in your body that's exchangeable. This remarkable formula he worked out in 1957 is true. It happens. This is a recent paper revalidating this this amount of sodium in your blood with the Edelman constant versus the measured sodium in a patient. This is from Horacio Droge. So this is really, it hits the nail on the head. If you use these tonicity formulas, this is work from Dan Taylor, one of my fellows, we can actually predict exactly what the sodium in a patient is if we take account of sodium and water and potassium and all these things. It's not just sodium and water. You have to look at tonicity balance. If you use these other equations like free water clearance, you will be wrong. And so we know these equations add up and they make sense. Now, the first person to actually say you can use balanced salt solution, which is isotonic solution, was Schreier. And Schreier was a surgeon in America, a trauma surgeon, and he said the only way we're going to save our trauma patients is to give them volume. So this was the first time in 1973 that we get a recognition that isotonic saline is acceptable and not dangerous. And you can see here experiments were done at that time. This is an amazing experiment in animals where they measured intracellular water. This was sepsis, so this was fluid requirements. If you gave large amounts of fluids in sepsis, you leaked. This is isotonic fluid. And if you gave dextrose water, you just leaked from the word go, because dextrose basically goes into your ICF space. So today, all of you as trainees will understand this. There is the ECF with the sodium as the main cation, and the ICF being twice the size of the ECF because it's got potassium and phosphate in the same amount. So 150 of potassium, 150 of phosphate, it's twice as big. And we know that you can then, if you give saline, the saline will stay in the ECF because it's isotonic. Actually, this 140, the true sodium is actually 155 in blood, but it's diluted by albumin by 7%. So 140 is not the true sodium. The true sodium in our blood is 155. And so isotonic fluid stays in the plasma, doesn't swell the cell. If you give 5% dextrose water, it has no tonicity because the dextrose gets utilized, and you basically drop the sodium, the cell water moves across the cell, and you get brain edema over here. So now we understand this idea of cellular swelling, giving hypotonic fluids promotes brain edema. And now when we think about fluids, we should ask what compartment we put in the fluid in. Because if we want to expand ECF, we give an isotonic fluid. If we want to expand ICF, we give dextrose water. And if you want to contract ICF, you give 3% saline. And so you can see here, if you use, for example, 0.45% saline, you will swell both compartments. So now we understand the intravenous fluids we're going to use are going to have an impact in where the fluid goes. And we have given, these are new studies in 2000, where we have given saline to normal controls. So if you give saline to people, the sodium stays at 140 here. If you give them dextrose water, the sodium drops. If you give them hypertonic saline, it goes up. So this idea that we're going to salt poison people isn't true. We see this at DKA, where they've measured intracellular pressure here, giving large amounts of fluids, just like the animal experiments will expand and cause brain edema. And we actually now can move on to work out caloric requirements relative to how much fluid you get. Now, it did surprise me when I looked this up, that if you look at all the organs in the body and add the kidneys, the heart, and the brain, which do 5% of the energy expenditure of the 80% of the energy expenditure of the body, you will see that the brain, the liver, the heart, and the kidneys only add up to 5% weight. So when we are using weight per kilo, we are actually only talking about a tiny amount of the body which uses this energy. So you can see here the original formula for fluids that you need, 100 mils per kilo per day. When we do it today and add it up, we actually only need about 30 to 40 mils per kilo per day in acute critical illness. And you can see these amazing experiments today where they go and measure energy expenditure in sleeping babies, crying babies, and you can see here you only need about 60, 70 kilocalories per day in these patients. And if you go and measure metabolic expenditure by a fancy machine in acute illness post-op, we only need about 42 kilocalories. So we are giving way too many calories to patients in acute illness. And I've already spoken about this, giving way too much volume here, just because the formula says if you 10 kilos, give 100 mils per kilo. Now, cell volume is actually regulated by chloride. Chloride is the crux here in terms of cell volume. So if you maintain cell volume and you maintain chloride, you will then preserve the integrity of the cell because you preserve tonicity. And so we move to the idea here that maintenance therapy is not replacing the sodium and the potassium. It's preserving cell integrity. Keep the cell volume the same, because then the cell doesn't swell and then we don't get misfunction of all the pumps. So to do that, when you're sick, you need restricted fluids. You probably only need about 2 to 4% dextrose. There is some good work showing we are giving children probably way too much dextrose. And we should be using isotonic maintenance fluid and obviously monitoring electrolytes. Now, the idea that when we started talking about this 20 years ago, everyone said, well, everyone will get hyponatremic. This is dangerous. So we move into the modern world where we realize there is some good evidence that this is not true. This is George Haycock, who was a neonatologist at Guy's and St. Thomas where I worked. He randomized a trial with premature babies, giving them 6 millimole per kilo per day instead of 3 millimole per kilo per day, and showed they had better IQ, better verbal performance, and better IQ following them up years down the line. So this is really, really a good paper. 10 years down the line, he showed that neonates should get much more sodium than what they're getting now. And that shows you something. Now, this is a really good reference paper for people who want to look at physiology. They gave, this is a German study, giving a whole lot of sodium to German people here. This is sodium intake, and they found something quite remarkable. Even though they gave loads of sodium to these groups here, if you look at day 1, day 5, day 13, 70, they all had the same sodium, and they all had the same ECF size. So this was a puzzle, because they're giving huge amounts of sodium to this group over here, but these people are not getting hyponatremic, they're not excreting the sodium, and they're not getting in positive sodium balance. So where is the sodium going? And now we know this fantastic study here looking at MRI, and you can see this great idea. They took tubes here with different amounts of sodium in, and they put the patients in an MRI. This is adults in an MRI scanner, and you can see here where the sodium is sitting in the skin and in the muscle and in the lymphatics. So now we understand we are storing sodium in places in our body that are not part of the vascular compartment, where we can get up to 400 millimoles of sodium. So this is here a study that you can see giving sodium to animals and then looking at the cartilage, and we can see here 450 millimoles of sodium here in an animal given sodium stored in the cartilage. So we have forgot that there's this big sodium space in the body where we equilibrate. And if you look at the new formulas now, the whole idea is called sodium storage disease. We are looking at sodium in the gel state in the blood, in the plasma, but also here in the bone and all these other organs that we never even thought about. So we can see that the sodium can move from the capillaries through the cells into lymphatics. And so we open the world of lymphatics, which we never even thought about. Now, this is a remarkable new set of data that's come out, is the lymphatics are the major controller of the movement of sodium and electrolytes in the body through AMP and BMP. And what happens is that when atrial natriuretic peptide and BMP are high, the lymphatic permeability here, lining lymphatic leaks, and the sodium and the potassium and the albumin will leak out of the lymphatics into the cells and don't get resorbed. So you can see here permeability. You can see here, control AMP, permeability, control BMP, huge increases in lymphatic leakage when we push the AMP and BMP levels up. So for example, if you are cardiac failure and you have high BMP, you are getting edema not because of the salt and water you're taking, but because your lymphatics are malfunctioning and you can't recycle the sodium. So this is a whole new world of traffic jam in the lymphatics that are now a major player in terms of the generation of fluid balance and sodium, and actually in terms of transport. And you will actually see that there are now tonicity binding protein. So there's something called tonicity element binding protein in macrophages that run up and down the lymphatics here, looking for sodium, looking for albumin, and they regulate this process. And this we really didn't know of until recently. So we have this idea here for us that we have ICF, ECF. We know tonicity is the balance in between, but how does fluid move from the plasma space, which is endothelial, into the ECF? And this brings the world of the glycocalyx, which is remarkable because maybe 10 years ago, they were looking at red cells in the microscope, and the red cells never touched the sides of the endothelium. And they dyed the endothelium with indocyan green, and they could find this big, thick carpet lining the endothelium where the red cells wouldn't bounce. And today, we know this is the glycocalyx. So this is a big, thick carpet. It's like Velcro. And this carpet here protects the gap junctions between the endothelium from leaking plasma. So the whole idea that albumin is a big player in colloid osmotic pressure has been thrown out the door, and now we move to the glycocalyx model. This thick carpet of glycocalyx is what stops leakage. This stops third spacing. You have to have this intact for things to work. And so we move to the capillary flux model. So instead of having this idea here in the past, we had filtration and absorption, we have colloid osmotic pressure. It's now just endothelium with gaps, and the glycocalyx is going to protect and stop things moving through there. And so in health, we see the glycocalyx is here covering the endothelium, but for example, in sepsis, the endothelium gets destroyed, the glycocalyx gets destroyed, and then you leak plasma. How do we know it's true? Look at this, remarkable studies. This is a healthy cell endothelium with this big carpet of glycocalyx, and this is in disease. It's completely cleaved off and gone. So the endothelium is raw and bare, and this will leak protein. And so we move into this tight junctions, fenestrated capillaries, and this is liver sinusoid. So the brain has very tight endothelial junctions because that's the blood-brain barrier. It has no lymphatics. Whereas other organs like the liver, the lungs, the gut, have these fenestrated capillaries, and fluid can move freely into the gut and the liver and the lungs. For example, when you get edema, this is why you get edema in those organs, because the endothelial glycocalyx is gone and they can't plug the gaps. So we move into a world where you can actually now measure the breakdown products of glycocalyx. This is a cross-clamping, aortic cross-clamping. This is a study by a guy called Marcus Rem. You can see huge rises in glycocalyx cleavage factors here when you go under bypass. Huge big rises of this is called syndecan 1 and heparin 1 that break away when you cross-clamp the aorta. And similarly, we did this work in kids at Evelina. With some of my team, we could cross-clamp children here. You can see bypass cross-clamp, and we can see here the glycocalyx fragments breaking off. We did this in DKA. You can do it in whatever disease you like. We now know endothelial glycocalyx disruption is a big player, even in vasoplegia. So this is a recent study in cardiac surgery adults. You can see here vasoplegia, no vasoplegia. You can see they have a complete breakdown of their glycocalyx from their bloodstream. So now we can start pinning these things together to make sense of fluid shifts and third spacing. So we can see here, the new model we should be looking at tonicity that controls the movement between ECF and ICF, but we can see the whole plasma space. We have endothelial glycocalyx and we have lymphatic. And these two channels together determine the integrity of how things work. Now, when we talk a little bit about fluid resuscitation, we want to talk about what type of fluids we give. I will show you here that it doesn't really matter. we need to give isotonic fluids and we need to give crystalloids as maintenance. And you can see here, this is just an example. This is an animal study. This is giving a whole bunch of different fluids, gelatin, starch, albumin, ringers. And you can see albumin is only preserved if you give albumin. This is colloid osmotic pressure is preserved if you give starches and albumin. Ringers has no effect on osmotic pressures. Does it make a difference? No, it doesn't. This is blood pressure. This is SVR. This is urine output. This is PO2s. This is interleukins. This is death. Doesn't matter which one you do. They are all the same in terms of their outcome. And now, if those of you who have read all your papers, there are a huge number of studies, crystalloids versus colloids, the SAFE study, saline versus albumin replacement in sepsis, balanced fluid versus non-balanced. You can go and read these huge, big randomized power studies, which we cannot do in children. And they basically showed it makes no difference whether you use a colloid or a crystalloid or a balanced solution or an isotonic saline. The fluid is not what gets you the outcome. The outcome is too much fluid, or conversely, your endothelial glycocalyx is broken down. So this is even work with albumin. You can go and look in the neonatal literature. Unfortunately, people still keep giving albumin nonstop all the time for sick babies. I will show you later how it makes no difference. We can even see in DKA that even giving DKA balanced solutions versus crystalloid does not change the outcome of DKA, the resolution of acidosis. This is a big study in adults showing the same thing. So it's pretty conclusive that the isotonic fluids are the key. The problem is we now have another dogma, and this is the hyperchloremia bandwagon. So I just want to spend a few minutes just finishing off on this, because this is something that really people are just jumping on the bandwagon without having a real idea of what it's all about. Now, if you look at the mortality of metabolic acidosis in ICU, you can see here lactic acidosis has the highest mortality, strong iron gap acidosis, 39%, the next highest. Chloride and no acidosis at all are virtually identical. So you do not die from hypochloremic acidosis. It has no impact on outcome. In fact, if we actually look at the outcome of different acidosis, it depends on the type of disease you have. So for example, here, neurotrauma, lactic acidosis is bad for you. Whereas if you actually look here in liver ICU, strong iron gap acidosis is what kills you. But in all of these, chloride behaves the same as no acidosis at all. Now, this is work from my unit in London when I was there. We showed hypochloremia, and this is the chloride sodium ratio. So if chloride is greater than 80%, we had 100% specificity of no death. So we showed that if chloride drops, in other words, if you are hypochloremic, you have an increased risk of death. Hyperchloremia in the CICU was a survival advantage, and never mind us, we had other people proving the same thing. This is Mark Hatherell in Cape Town, looked at open heart surgery and found exactly the same thing. Hyperchloremia was a predominant acid-base abnormality. It was associated with a reduced requirement for adrenaline therapy, suggesting it is a benign phenomenon that should not prompt escalation in hemodynamic support. And he went on to do other studies in children with shock, for example, and you can see here survivors, non-survivors. Survivors had hypochloremia, sodiums of chlorides of 114 versus non-survivors, sodiums here of 111. So hypochloremia in the PICU is a survival benefit. We should not be chasing chloride because it's there for a reason, and physiologically it's there to protect you. Now, how we understood this is a paper I published in 2001, which is a really, really long time ago, where we actually looked at this word chloride sodium ratio. No one had ever referenced chloride and sodium in the literature up to this point. And we found that the more tissue acids you have, the lower the chloride was, and basically the less tissue acid you had, the higher the chloride. So if you are hypochloremic, 80% of your chloride here, you are protected from acidosis because the acids will find it harder to get into the electroneutral space. And you can see here, this is a paper from one of my fellows looking at the base deficit due to chloride. You can see chloride can alkalize you or it can acidify you. So chloride is as good at alkalizing you half the time in CICU that it is acidifying, and we should be able to look at these components when we measure it. Now, I do want to mention something, because everybody who talks about hypochloremia never ever mentions sodium at the same time, and everybody who talks about hyponatremia or hyponatremia never references them at the same time. So I just want to show you a couple of examples here. This is a normal situation: sodium 145, chloride 105, chloride is 72%. You can have hyponatremia, sodium of 125, with severe hypochloremia. If your chloride, for example, is 105, this is in the normal range. Chloride ratio is 84%. So you can have hypochloremia with hyponatremia, and this will give you a different mortality based on these two things together. So it's not just the low sodium that's important. And similarly, you can have hyponatremia that is severe with normal chloride, even though the chloride value is in the lab in the toxic range. And so I really plead to people that when you analyze sodium disorders and we talk about hypochloremia, hyponatremia, we start looking at these together. And the key is that it's the solutions we use. Now, I just want to say one word before I wrap up, actually, on balanced solutions, because this is something that annoys me a lot. People talk about balanced solutions, but there is no such thing as a balanced solution. So this is a bag of saline, sodium 154, chloride 154. This is not a physiologic fluid by any stretch of the imagination. I've already showed you that if you give this solution, you will not die from hyponatremia. You will probably get hyperchloremia, but the mechanism will not be because you're giving chloride. It's because the body physiologically retains chloride when you have another anion like ketones or lactate, for example. So hypochloremia, universal in DKA as a protective reflex by the body. Now, the only solution intravenous that is balanced, that has the exact amount of sodium and chloride and bicarb in the plasma, is plasmolite B. The problem with plasmolite B, if you put bicarb in a bag, it gets converted to CO2. The CO2 will get excreted out of the bag. It will diffuse out of a plastic bag and will leave you with only sodium and chloride. So if you want to use plasmolite B, you have to use a glass bottle. So the reason this solution is not used anymore in modern medicine is because you can't transport big glass bottles around, and it's much easier to move a plastic bottle around. So that's why this, the only true balanced solution that exists, is not available to most people because it's in a glass bottle. If you go to ringers or solution like that, which everybody says is physiologic, so people will tell me that a bag of ringers with 26 millimoles of lactate is physiologic. Well, 26 millimoles of lactate is not physiologic. 2 millimoles of lactate is physiologic, but not 6. So all you're doing is you're substituting different anions, whether it's chloride, whether it's bicarb or lactate. These solutions will have no impact in your final outcome because, as we said before, your final outcome depends on the integrity of the glycocalyx. So if I summarize where we are with fluids now, because we've gone from the whole history of how we were misled by Holiday and his formula, which was just done in 52 children, and now we can actually put everything together. So we have integrity of the endothelium as the key feature, whether you leak fluid or not, that you're given intravenously. We have tonicity balance, the movement of fluid between ICF and ECF, which is controlled by sodium and regulated by chloride inside the cell. And then we have lymphatics, which is a brand new world here, the entire world of lymphatics, how these regulate a salt and fluid balance, how AMP and BMP play a role in this. And this is the circle in terms of what we get. If we break the circle, the blood-brain barrier is there. The brain has no lymphatics, and this is why the brain will get cerebral edema if we actually break these defenses down. And this is a mechanism why many, many, many children have died historically because of this. So if I can briefly summarize, we have the plasma space, which we now know is related to endothelial integrity. We have fluid balance, which is related to sodium balance. We have sodium balance related to tonicity, which includes potassium. We have cell regulation by chloride, which controls all the pumps. So if the cell volume is regulated, this controls how well all your pumps work. And then we have sodium stored in lymphatics, which is a new process, a new disease which we're looking into. And in all of these models, we actually see that albumin does not play a role. You can be born without albumin and you will not have edema. So this is why albumin solutions don't make a difference to outcome. Either way, if your sodium is low, you will get cerebral edema, and I'm sure that will be the focus of some of the talks later on. So in my last slide, I'd really stress to you, it was a very, very good learning lesson when we went down the history lanes, looking where all the information comes from the textbooks. So this is my mentors. Des Bone is a huge person in the whole isotonic fluid debate from 20, 30 years ago. Midge Halperin was a nephrologist in Toronto who worked on tonicity balance. And I implore you all, if you want to read his book, this is the best book on fluid and electrolyte balance you will find. He died a few years ago. This is really a book that explains all the cellular mechanisms and things that I've spoken about. Thank you very much for listening.
Thank you, Andrew, for that fantastic talk. So elegant, taking us through history and challenging the traditional concept of fluid therapy, especially the maintenance fluid therapy, and also throwing light so beautifully on the recent concepts of endothelial glycocalyx. It's been wonderful listening to the talk, and I'm sure all the participants and other panelists would share the same sentiments as what I have expressed. I was just looking at the chat box. I don't see any questions. I feel everyone was completely mesmerized by your talk.
Or asleep.
That's what it seems like. Spellbound. That's what I can see. One comment which says spellbound. Absolutely fantastic. Mesmerizing. Amish, if somebody wants to kind of, are there any questions on the YouTube chat box that, Amish?
No, madam. Over there is the same thing. It's all compliments for making it really basic to understand. It was something which people thought, did not think, in fact, and there were a lot of things that people came to know about it. And I think we can take it to the next speaker, and we can see Arun, and we can get Arun to start talking, madam.
Thank you, Andrew. Thanks
Thank
a lot
pleasure.
for enlightening us. It was an absolute pleasure listening to you.
Thank you. Thank you.
With this, we go on to the next moderator and speaker. So it gives me immense pleasure to introduce my colleague and co-faculty, Professor Arun Bansal, who is Professor of Pediatric Critical Care at the Advanced Pediatric Center, PGIM at Chandigarh. And his key area of research is the neurocritical care. So Arun, along with his fellow, will take you through interesting cases to drive home the point about how important fluids are in CNS disorders. And I now hand over the mic to Arun to take you through the next session. Over to you, Arun.
Thank you, ma'am. And thank you, Andrew, for a nice lecture and taking us through a nice history, which probably most of us were not aware. So moving forward, on the fluids in CNS disorder, and another interesting topic, part of which was slightly touched by Andrew also. What we'll be doing is we'll be taking up a couple of cases in which we'll see the similar kind of presentation, but different kind of fluid regimen and requirement and different problems. And then we will discuss something about latest evidence on that how we can what kind of fluids and how we can approach that different pathologies or physiologies. So to help me that in this, our own DM student fellow, Dr. Muthuvel, is here. He will be presenting the cases and then we can discuss subsequently on that. So Muthuvel, you are there?
Yes, sir.
Yeah, you can start sharing. So Muthuvel is our DM senior resident. He is currently doing the DM in pediatric critical care at PGI Chandigarh. So he will be presenting the cases. So please, Muthuvel.
Are my slides are visible, sir?
Yes.
Good evening to all. I thank IAP Intensive Care Chapter Mumbai for giving me the opportunity to present in this forum. Today we will be discussing about fluid therapy in CNS disorders. So the fluid management in critically ill brain injury patients is more or less similar to fluid management in other systemic illness patients. Mainly we will give the fluid management mainly focuses on maintenance of adequate intravascular volume and maintaining tissue perfusion and keeping adequate urine output and electrolyte and glucose homeostasis. Likewise, in critically ill brain injury patients also, the main aim of fluid management is to maintain adequate cerebral blood flow and oxygenation. However, there are some distinctive features in fluid management in CNS patients versus non-CNS critically ill patients. One is the maintenance of plasma tonicity, which is very important in CNS cases to avoid the risk of cerebral edema. And the present cerebral edema can aggravate impaired cerebral blood flow also. And the fluid management is a basic care in patients with CNS insult. However, it's a part of intensive care in patients with systemic illness. And optimizing cerebral blood flow with adequate fluid management is more challenging in CNS cases than children with systemic illness, because the tools for monitoring cerebral blood flow and cerebral oxygenation, they are limited in resource limited settings. And the fluid management practices are highly variable because most of the guidelines available are of low quality evidence. So as we all know, the fluid homeostasis mainly depends upon the plasma osmolality and volume status. The plasma osmolality is governed mainly by the water content, and volume status mainly governed by the sodium content. So whenever there is a disruption in homeostasis, whenever there is an increase in ECF volume by fluid gain or fluid and sodium gain, there occurs increased blood volume and atrial distension and natriuretic peptide release, and subsequent events leads to reduced water intake and increased urinary loss and increased urinary sodium loss to restore the homeostasis back to normal. Likewise, whenever there is a decrease in ECF volume and decrease in sodium and fluid content, similar events happen, results in increased renin angiotensin aldosterone system activation, which results in increased urinary water retention, decreased urinary loss, and increased water intake, which leads to restoration of the homeostasis back to normal. Then the effect of fluid management on cerebral blood flow and cerebral oxygenation. Lot of intermediate factors affect the fluid administration and the volume status on the cerebral blood flow and oxygenation. These include the intactness of the blood-brain barrier, CSF circulation and volume, inflammation of the brain parenchyma, and the cerebral autoregulation, and venous impedance of the cervical blood vessels, and systemic circulation with the presence of shock and vascular tone and permeability. All these factors can affect the cerebral blood flow and oxygenation. And one of our main aim of fluid management in patients with neurological illnesses to prevent further brain injury, that is to prevent secondary brain injury. Secondary type of brain injuries are called, they are further cellular damage from the effects of primary injuries. They develop usually over a period of hours or days following initial inset. They are mainly mediated through excitatory amino acids, endogenous opioid peptides, increased intracranial pressure, and presence of cerebral edema, hydrocephalus, and brain herniation. So the relationship between volume status and secondary brain injury. In this picture, we can see that presence of hypovolemia and hypervolemia both are associated with less successful prevention of secondary brain insult. So the strategy should be maintenance of the euvolemia to prevent secondary brain insult. So with this, we will discuss two case scenarios. Case scenario one is a baby J, a 7-year-old female child resident of Ambala, Punjab and India. The child presented with complaint of fever for initial 6 days, followed by seizure and altered sensorium for 2 days. On history, the fever was initially of intermittent high grade in nature up to 103 Fahrenheit with 3 to 4 spikes per day, not associated with chills and rigor. For the fever, initially the child has been given oral medication from local practitioner. After 4 days of fever, the child started to develop tonic-clonic movement of left upper and lower limb, which are associated with uprolling of eyeball and frothing from the mouth. Followed by the child become lethargic, child become unconsciousness. However, there was no history of any headache, vomiting, no history of any viral prodromal symptoms, abdominal pain, no history of any drug intake. With these complaints, the child has been taken initially to a nearby hospital where, in view of poor sensorium, the child got intubated there and the child has been put on mechanical ventilation for 24 hours. but the child continued to throw up seizures. Hence, the patient has been referred on next day to our institute. On past history, there was no history of epilepsy in the past. Family history, there is no family history of epilepsy and no history of any febrile illness in other family members, and there is no history of any contact with the tuberculosis. Other histories in the child are irrelevant. So when the child presented to us in a triage, airway wise, the child was on intermittent positive pressure ventilation, and breathing wise, the child was on, efforts were poor, however, the RNG were equal, saturation was 97% on IPPR. Circulation wise, the child has the heart rate is of lower side, and blood pressure is more than 90 centile for age. However, the central peripheral pulses were good, and ECG is not suggestive of any arrhythmias. And the child is having altered sensorium with the E3 and VT and M3 status. The tone is increased in all 4 limbs. So initially, we have classified as the primary brain systemic dysfunctional respiratory failure. So the resuscitation should be level 1 urgent. So on systemic examination, chest and CVS finding were normal. On CNS examination, it remains the sensorium is E3, which is meaningless eye opening, and VT and M5. And tone is bilateral hypertonia is present with intermittent decorticate rigidity posturing is also there. And child is having hyperreflexia in all 4 limbs and extensor plantar response in all 4 limbs. And the child had features of meningeal signs also. So here in the database, we have a baby J, 6-year-old developmentally normal child presented with acute onset fever followed by left focal seizure with altered sensorium. On examination, the child has respiratory failure and features of raised intracranial pressure, hypertonia, hyperreflexia in all 4 limbs, and plantar for extensor. So we initially kept a possible diagnosis of acute encephalitic syndrome with raised intracranial pressure. The differential diagnosis kept was viral meningoencephalitis, suspected herpes simplex or Japanese encephalitis. So the course during PICU stay, after admission for airway and breathing, the child has been put on mechanical ventilation. We have continued on, we have put on pressure support SAMV mode of ventilation. On day 5, the sensorium has improved, hence the child got extubated and put on Romier on day 6. Circulation with the child was initially hemodynamically stable. At time of presentation, we have started IV fluid, isotonic fluid, DNS at 80%. Late for 48 to 70 hours, then it has been shifted to tube feeds. So the reason for starting restricted fluid in this kid, we will be discussing later. And seizures wise, the child didn't have any seizure at, here, so we have continued the maintenance dose at phenytoin 8 mg per kg per day and levetiracetam at 60 mg per kg per day. For raised ICP, initially we have given first tier anti-raised ICP measures, 3% saline bolus followed by infusion. And we have continued, we did invasive ICP monitoring, which was high. We removed the catheter on day 3 of illness, and the ICP became normalized. For suspected meningoencephalitis, we given antibiotic and antivirals. On day 6, the child PICU need became passive, so the child has been shifted to neurological ward. So this is one case scenario of a child presented with acute viral meningoencephalitis with raised ICP. This is another scenario where Master V, a 11-year-old male child who is a resident of Shimla, Himachal Pradesh, India, has presented with complaint of on and off fever for past 1 month and headache and photophobia for past 15 days and weakness of left side of body for past 1 day. So the fever was high-grade fever, intermittent up to 102 degree Fahrenheit, which are associated with intermittent chills and rigor, 1 to 2 spikes per day. However, no diurnal variation. After 15 days of fever, the child started to have headache, which are predominantly over occipit, early morning headache, which are associated with intermittent projectile vomiting. It is also associated with there is a progressive aversion to sound of light, that is photophobia and phonophobia. So the child prefers to stay in a quiet dark place. So 1 day prior to presentation, the child had rapidly progressive weakness of left upper and lower limb with deviation of the angle of the mouth to left side associated with altered sensorium in the form of inappropriate laugh and cry and not recognizing parents. However, there is and it's associated with history of decreased appetite. There is no history of blurring of vision or slurred speech, no history of cough, hemoptysis, fast breathing, and no history of seizure. So when the child had fever in the first week, the child was admitted in IGMC Simla for 1 week, where they did workup for tuberculosis and they did neuroimaging and EEG, which was absolutely fine. So the child has been given some IV antibiotic and the child was discharged. So past history wise, there is no history of similar illness in the past. Family history, there is a contact with pulmonary tuberculosis. That's a history of pulmonary cox open case in maternal uncle 1 year back. and there's no other significant positive history. So when the child presented to us in triage, the airway was open and stable. Breathing was absolutely fine, and the child was maintaining saturation 97% room air, and circulation is also normal with good central and peripheral pulses. With BP is also normal. Disability wise, the GCS, the child has altered sensorium, E4 meaningless, and B2 and M5 response there. The tone is asymmetrical, and left side hypertonia is there. Our bilateral pupils are 2 mm and reacting to light. So initially we classified into primary brain and systemic dysfunction, and resuscitation was level 2 emergent. So on systemic examination and the CVS and chest examination were normal. On CNS examination, child was an altered sensorium. On examination, there is a left side hypertonia, and power is more or less normal in right side. However, it is decreased in left upper and lower limb, and the reflexes are hyperreflexic in left upper and lower limb. There are features of upper motor neuron signs are present. The plantar also extends are in left lower limb, and meningeal signs also was there. So in database, we have Master V, 11-year-old male child with intermittent fever for 1 month and progressively increasing headache and photophobia with acute onset left side weakness and altered sensorium. On examination, the child had encephalopathy, left upper limb and lower limb, upper motor neuron weakness, and meningeal signs. So diagnosis, we get a chronic meningoencephalitis with left hemiparesis. So the differential diagnosis in view of contact history with tuberculosis and prolonged history and high prevalence of tuberculosis in India. So the first preference we kept was tuberculosis meningitis stage 3. So for during the course, during PICU stay, for airway and breathing, initially the child was on room air. On day 3, the child started to show features of raised ICP, and sensorium worsened, so the child got intubated and put on mechanical ventilation. However, after 48 hours, the child has been extubated and put on room air. Circulation wise, the child was hemodynamically stable. Initially, this child also has been started on IV fluid at 80%. Later, within 2 days, it has been increased to 100%. With, along with, we have replaced the deficit volume also. The child started to have polyuria, so we have replaced his volume. So we will discuss the fluid management in this case also later. Later, we have shifted to tube feed. For raised ICP, we went first era anti-ICP measures. Then we did CT brain, which was suggestive of communicating hydrocephalus. So we did medium pressure ventriculoperitoneal shunt on day 3 of hospital stay. Afterward, the sensorium has improved, hence the child got extubated. For chronic meningoencephalitis and suspected tuberculosis, we have started anti-tubercular therapy with steroid. For stroke, we have started oral aspirin and shifted to neuroward on day 6 after PICU needs became over. So in both these cases, when they have presented, they had hyponatremia. So approach to hyponatremia and fluid management in these cases will be discussed later. And the objectives of this presentation were dysnatremia and CNS disorders, and what amount of fluid volume that we have to choose, and the choice of fluid that we have to choose in children with CNS disorders, SIADH and its pathophysiology, and the cerebral salt wasting syndrome and its pathophysiology. So how we can divide decide the amount and type of fluid that has to be administered in children with CNS disorder. It should be always based on the serum sodium level, whether the child is eunatremic or hyponatremic, and volume status of the child, whether it's euvolemic or hypovolemic. So dysnatremia is very common in CNS disorder. The most common dysnatremia we observe is hyponatremia, which is a commonest electrolyte abnormality in children with CNS onset or infection, and it is also associated with increased morbidity and mortality in children. The prevalence of hyponatremia is around 50% at admission in children. So Zeng et al. Did a study to observe the frequency of hyponatremia in children with bacterial meningitis. It's a retrospective review of 175 children with bacterial meningitis were taken. He observed that hyponatremia was present in 66.4% of the patients at the time of admission. Mild hyponatremia constitutes 77 children, and the moderate and severe hyponatremia was there in 14.8% and 7.4% of children. And he also observed that the moderate and severe hyponatremia were significantly associated with increased risk of seizures, low minimum GCS scores, and impaired consciousness, and the presence of systemic complications like shock and modes, and requirement for ventilation and longer duration of hospital stay. However, hyponatremia was not associated with any development of neurological complication at discharge. So how hyponatremia develops in CNS disorders? The The causes may include syndrome of inappropriate antidiuretic hormone secretion. This is the most commonly observed thought, and other causes include cerebral salt wastage syndrome, and iatrogenic causes include excessive fluid administration, excessive hypotonic fluid administration, and hyperosmolar therapy for raised ICP with mannitol, which leads to diuresis and atriuresis. Thereby, it can cause hyponatremia. So, in the case scenario 1, the serum electrolyte values were at admission, the sodium was 128, child was having moderate hyponatremia, and chloride is also at lower side. However, the urine output is normal, and the child didn't show any features of dehydration. So what should be the appropriate amount of fluid to be administered here, that we will discuss later. So in CNS disorder, there is a debate versus there is a debate on restricted versus normal 100% maintenance fluid administration. Fluid restriction, the thought of fluid restriction was advocated earlier. The rationale behind fluid restriction is presence of hyponatremia secondary to syndrome of inappropriate antidiuretic hormone secretion. The SIADH leads to euvolemia and hyponatremia. If we give excessive fluid in this case on normal maintenance fluid, it may lead to exacerbation of cerebral edema. So the prevalence of SIADH in children with hyponatremia and CNS stroke usually ranges from 7% to 88%. This high variation in the prevalence mainly due to differences in the definition of SIADH used. SIADH definition and diagnostic criteria came out recently. So before that, there was no specific criteria. Because of that, that's a discrepancy in the prevalence. So the causes for SIADH, any CNS abnormality can enhance the ADH release from the pituitary gland. The most common causes include stroke, intracranial hemorrhage, intracranial infection, traumatic brain injury, psychosis. So initial injury stimulates neurons in the supraoptic and paraventricular nucleus of the hypothalamus, which leads to excessive secretion of ADH, which are not osmotic in nature, and increased expression of aquaporin channels with the collecting duct, which results in inhibition of the free water clearance and excessive water retention and extracellular volume expansion. This extracellular expansion suppresses the plasminogen activity and enhancement of the brain natriuretic peptide secretion, which leads to natriuresis and restoration of the euvolemia, but worsening of hyponatremia. That's why in SIADH we will get euvolemia, not hyperolemia, but hyponatremia will be there. So the diagnostic criteria include absence of renal, adrenal, thyroid insufficiency, and there should be an absence of cardiac failure, nephrotic syndrome. There should be absence of diuretic ingestion, high urinary osmolality in the presence of low serum osmolality, and high urinary sodium excretion in the presence of low serum sodium excretion. And there should be a reversal of sodium wasting and correction of hyponatremia with water restriction. So what is the evidence for SIADH and fluid restriction CNS infection? And Kaplan et al. Did a study to assess the plasma concentration of the arginine vasopressin level by radioimmunoassay in 13 children with 13 controlled normal children and 21 children with febrile illness of non-meningitic etiology and 17 children with meningitis. And he observed that the arginine vasopressin concentration level was significantly higher in patients with bacterial meningitis than normal children or children with other febrile illness. So in these children with meningitis, they have given restricted fluid, which leads to increase in the serum sodium and urine output in this cohort. And this study was done in our institute, where they have assessed the changes in the body water compartment in children with acute meningitis. They have studied 30 children of 2 months to 5 years old. They have calculated total body water and extracellular water at admission, as well as after 48 hours. They found that the total body water, extracellular water was significantly higher in children with meningitis on day 1 than in controls, whereas the value after recovery are similar to controls. And children who had complications and sequelae had much higher extracellular water than those children who recovered completely. And fluid restriction may prevent further increase in extracellular water. Then comes the normal maintenance fluid, that is liberal fluid in CNS infection. This is the most commonly used practice nowadays. The rationale behind this, the hyponatremia which is present in CNS disorders is mainly secondary to dehydration. Most of the children with CNS infection may present with vomiting and poor oral intake and excessive urine loss. And the increase in ADH concentration in children with CNS infection is appropriate. It is not inappropriate. It is secondary to hypovolemia. And maintenance of normal volemia is necessary to maintain cerebral perfusion pressure. These are the rationales behind giving normal maintenance fluid in CNS infection. So in this study, Narottam et al. they did a controlled prospective study of 24 patients with tubercular meningitis with hydrocephalus, and they found that 15 patients were hyponatremic at admission and 9 patients were not hyponatremic, and there was a moderate negative and they measured plasma HCl natriuretic peptide and the ADH level in children with hyponatremia, and they found that there was a moderate negative correlation was found between plasma HCl natriuretic peptide and serum sodium concentration. However, there is no correlation was found between the ADH level and serum sodium. So it therefore appears that plasma HCl natriuretic peptide accounted for 65% of the variation in the plasma sodium, while ADH account for only 3%. So the main change in sodium value, the change in sodium value is mainly because of increased level of the natriuretic peptide level. So in these conditions, there will be excessive natriuresis, so we have to give more fluid. And an RCT has been done to compare the restrictive versus normal maintenance fluid in CNS infection. And in this study, they measured the plasma arginine vasopressin concentration after giving maintenance plus deficit replacement fluid versus restricted fluid for 24 hours. 19 children in the age group of 2 months to 17 years were enrolled. In that, 10 children received a mean of 1.42 times calculated maintenance fluid, and 9 children were received a restricted fluid of 65%. And they found that the plasma arginine vasopressin level was significantly lower after 24 hours in maintenance in children who has received a maintenance with replacement therapy than fluid restricted group. It shows that the secondary rise in arginine vasopressin level is mainly because of hypovolemia, not because of SIADH. So this was another landmark study which was done in our institute. It's a prospective study to assess the fluid, to examine the effect of fluid restriction on body water and the outcome of children with acute meningitis. 50 consecutively hospitalized children with acute meningitis were divided into 2 groups, a group A without hyponatremia and group B with hyponatremia, and they were randomly assigned to receive normal maintenance fluid or restricted fluid for first 48 hours. They measured total body water, extracellular water, serum urine, sodium and plasma osmolality at admission as well as at 48 hours. And they found that children with hyponatremia have increased total body water and extracellular water. And children who received restricted fluid, there is a significant decrease in the mean total body water and extracellular water, whereas children who has received normal maintenance fluid, there is no change in the extracellular water. However, the significant decrease in extracellular water is associated with increased risk of mortality. So in conclusion, there is no recommendation from Brain Trauma Foundation guidelines also regarding the amount of fluid to be used in children with traumatic brain injury. So there is insufficient data to make recommendation about the empirical management of regarding the empirical fluid therapy in children with CNS disorder. However, the volume of fluid administered should be individualized and it should be sufficient enough to maintain the cerebral perfusion pressure. It depends upon the sodium balance and volume status of the individual. Then comes the choice of the fluid in CNS disorder, whether we have to administer isotonic versus hypotonic fluid. We all know isotonic fluid is the mainstay of maintenance therapy to avoid the risk of cerebral edema. Administration of hypotonic fluid may lead to iatrogenic hyponatremia and further worsening of hyponatremia in children who already have. However, there is no control trial assess the efficacy of isotonic versus hypotonic fluid in children with CNS infection. So this is a study, it's a prospective randomized control study conducted in 3 PACU, where they have compared the hypotonic versus isotonic children in critically ill children, not CNS infection. So in this study, 120 children were included. 60 children received hypotonic fluid and 63 children received isotonic fluid. And they found that patient receiving hypotonic fluid had 5.8-fold increased risk of hyponatremia during the study period. However, those children who received isotonic fluid didn't develop hyponatremia or hypernatremia. So still, there's no recommendation regarding the choice of maintenance fluid in children with TBI. On conclusion, isotonic fluid should be the choice of maintenance fluid in children with CNS infection or insult. So when coming to the case 1, the fluid therapy, initial blood investigation of that child showed sodium of 128 milligrams per liter. However, there is no signs of dehydration and urine output is adequate. It is not high also, and the blood pressure was maintained between 50 to 90 centile. So initially we kept the possibility of suspected SIADH. Hence we have treated with fluid restriction, and the child has improved also. Coming to the case 2, the case 2 child also had hyponatremia. However, on day 3 of hospital stay, that is post ventricular peritoneal stent surgery, the child had progressive hyponatremia and the child developed polyuria also. The serum sodium was persistently low. It was 122 milliequivalents per liter, and the child appears dehydrated, and urinary electrolytes also very high. And we have ruled out the renal cause of hyponatremia. So what could be the possibility in this child? Here it comes the cerebral salt wasting syndrome. The pathogenesis of CSW includes any insult to the brain, predominantly around the ventricles, or dilatation of the ventricles leads to increased sympathetic activity to maintain the cerebral blood flow. It increases the cardiac output, and this increased sympathetic activity and increased level of dopamine increase the renal perfusion also. Along with that, brain injury causes release of natriuretic peptides, predominantly C-type natriuretic peptides from the ventricles and ependyma, and which acts on proximal and distal collecting ducts, results in natriuresis, volume depletion, and hyponatremia. So differentiation of cerebral salt phase syndrome from SIADH is of paramount importance because the treatment is different for each disorder. In the cerebral salt phase syndrome, we have clinical evidence of volume depletion. However, in SIADH, we won't have. The plasma sodium level is decreased in both. However, the urinary sodium and urinary flow rate are markedly high in cerebral salt phase syndrome. It is variable in SIADH. In the plasma renin activity, aldosterone and ADH levels are reduced in cerebral salt wasting, mainly because this HL natriuretic peptide inhibit the renin angiotensin activity in aldosterone level also. However, it appears increased in SIADH. So the management of cerebral salt wasting is aggressive replacement of urinary salt and water loss with 0.9% normal saline or 3% saline. And there is some role of mineralocorticoid in the cerebral salt wasting. The rationale behind this, there is a suppression of renin angiotensin and aldosterone syndrome by increased in natriuretic peptide. So supplementing corticosteroid may help in fluid retention. And multiple case reports are available. However, there's no randomized controlled trial done to assess the efficacy of mineralocorticoid. Fluorocortisone has been used at 0.2 to 0.4 milligram per day for 2 to 3 days. However, they have not seen any consistent effect. So the take-home message from these case scenarios include dysnatremia is a common enteroid abnormality in CNS infection, and the amount of fluid what we are giving should be sufficient, whether it is restrictive or normal maintenance. It should be sufficient enough to maintain the cerebral perfusion pressure and tissue oxygenation, and the choice of fluid should be of isotonic. And cerebral salt wasting syndrome should be considered in children with persistent hyponatremia and natriuresis, because the treatment will be different from SIADH. In SIADH, we have to give fluid restriction, and cerebral salt wasting, we have to give liberal fluid and hypertonic saline. Thank you.
Thank you, Mutfal. You can stop sharing the screen. Yeah. So, Mutfal, you have nicely presented two cases in which they can have different physiology behind, and the approach is different. But the basic concept is that you have to maintain the euvolemia. That is the most important part. You have to target the fluid and the type of fluid based on the sodium levels. All the treatment is based on that. And then what compartment of dehydration or the volume which you are targeting, whether it is intracellular, extracellular fluid, or what is your aim of giving the fluid, that and what kind of pathology the child is having. I think you have explained it well. We can have any discussion on that. Any questions we have on this? We can take it up. So I don't see any questions in the chat box.
Yeah, there are none in the chat box. Yeah.
Yeah. So, but any of the panelists here who want to ask any question or any comments on this?
Hi, just to say, I thought that was a fantastic talk. So well done on that. And I'm just glad that you're using isotonic saline as your baseline. I think, as I've said to you before, there's a lot more now about sodium that we understand, AMP, BMP, lymphatics, glycocalyx. So I think there'll be a lot of research now into, where we go and how we protect the brain, etc. But it's a new field. So well done. Fantastic talk.
Yeah, thank you, Andrew. And earlier we used to give the restricted fluids, but not now. We are using and that we were doing the hypertonic fluids earlier, but now we are moved to the isotonic fluids as a routine in all the cases. And the restricted or the normal fluid depends upon the physiology or upon the sodium levels or what kind of disease we are targeting. So any other comments?
Arun, there are some questions in the chat box.
Dr. Arun,
okay.
Dr. Arun.
Hanji.
Yeah.
Yes.
Yes. Sorry. there's little bit confusion, if you look at the previous talk, and in general, we recommend that patient on ventilator, their requirement is very less when we talk about fluid requirement. But what we are talking about is full maintenance. Full maintenance is your typical old formula. So in a given patient, in most of the patient, if patient is suffering from CNS disease, you recommend that 100 ml per kg for 10 kg, then, or you start with 70% or 60%, and then you jump on to, once you define the sodium, define the volume status, and what you do in your practice and what you recommend for the people.
Okay, yeah, that's what I think most of the questions in the chat box are also, that should we restrict the fluid and 2/3, 80%, 70%, or any fixed value. So, and usually what we do is we start with around 80% in all these disorders. We monitor their urine output and their electrolytes. And once we are more clear, then we decide whether we have to continue the same or we have to give a liberal fluid or a 100% fluid on that. So I think that's a good approach to follow. But we always use isotonic fluids now. So that is what we are more clear on that.
Okay, thank you.
So Muthuvel, you want to answer this question, that whether we should restrict the fluids or we have to, and how much restriction is important, 2/3, 70% or 80%?
Regarding restriction of fluid, there is no clear-cut guideline, and in studies have shown that even in RCH guideline also, they have restricted fluid to 50%. They will start with 50%, and based on the serum sodium level and volume status, they will hike the fluid. So restriction usually means between 50 to 70%.
Yes. So we need more data on this, that what do we mean by restricted? At present, we don't have the exact percentages on that. So it is basically all individualized, and we, based on the volume status, we have to decide that how much fluid we have to give to each patient. So then there is a question on this, that any role of 3% saline in cases of SIADH. Muthuvel?
There is no role of 3% saline in SIADH, sir. SIADH is mainly of it's of dilution hyponatremia. It's of, even though there's a euvolemia, it's associated with hyponatremia. We have to restrict the sodium. That way, we have to raise the serum sodium level. We have to restrict the water intake and fluids. That way, we have to raise the serum sodium level.
Very good. Also, how do we decide the fluid status in this, Muthuvel? We can then we can take it up that whether you take the heart rate, blood pressure, lactate, perfusion, are these good enough, or are there any other parameters to judge that patient is hypovolemic or euvolemic?
So for to check whether the patient is hypovolemic or euvolemic, clinical examination and these parameters are good enough to judge the fluid status. That's BP and lactate and perfusion and cerebral perfusion.
Yeah, and I think along with it, we need to have a intake output monitoring is also very important in this, and then the electrolytes, and they are also equally important. So clinical examination, your fluid intake output, and your labs, this will help you in that.
So,
yes.
Will you do your urine electrolytes to decide about the fluid in this situation, or only on the serum electrolytes will we decide?
Yes, if we are, say, suspecting SIADH or CSW, we routinely do then urine electrolytes in our cases to decide the what differentiate between these two conditions, all the CSW and SIADH. And we have this facility, and this condition can easily, urine electrolytes can differentiate very well between these two conditions. So it is advisable to get this done.
Or you do the serum osmolality and urine osmolality and decide about it in that situation?
Urine electrolytes and is very important, and we sometimes do osmolality also. Yes.
Because some of the patients, like in the CSW, they may, or in a SIADH, in spite of restricting the fluid, sometimes you may not rise, the serum sodium may not rise, and you may have to restrict further. So how you take those decisions on that?
It's a very difficult and it's a good question, and it's a very difficult management that once we start restricting the fluid, the serum sodium may not rise. But then that if we are sure that it is SIADH, we can then further keep on reducing as long as we are not causing too much harm with good monitoring and with good labs. So that's I think that's how we do at these cases. But sometimes it is tough. I agree with this.
Yeah, and the cerebral salt testing in this situation, how frequently you do serum sodium? Because suppose there's a lot of electrolyte losses, and they are polyuric also sometimes. So how frequently we should do an electrolytes, and what should be our replacement of volume and the sodium in those situations?
Yeah, Muthuel, you want to answer this?
In most of the child presented with CNS infection and raised ACP, we usually give 3% saline also to maintain to prevent cerebral edema and to maintain the sodium between 145 to 155 milliequivalents per liter. So in that condition, we usually monitor the sodium value 6 to 8 hourly.
And how frequently you replace the fluid? Means like, and you would want to replace every 6 to 8 hourly or hourly basis on those basis in those patients who have cerebral salt disease.
That we usually do in our ICU, it is 4 to 6 hourly we replace the fluid. If the urine output is more than 4 ml per kg per hour, we usually replace 4 to 6 hourly.
Yeah, because those
so
are
what we do is,
I think
yes.
interesting discussion, and we're going to nitty-gritty, and we need to, I'm sorry, but for the sake of time, we need to please move on. And so, Jayashree ma'am and Arun ma'am, Andrew, can we move forward? And
Amish, there is a question for Andrew now, I see. So,
sure.
Yeah.
Is it okay if we put it across to him or
Yes, please
later?
do, ma'am. Please do.
So, this question says that is the Holiday-Sagar formula still to be followed for calculating maintenance, albeit with isotonic fluids?
As I've said before, it's the only thing there is. But I think people, a lot of the debate here is restriction or not. You don't need the calories because the fluid is there to give you calories. Fluid is there to replace losses. So I think it's really important people just be sensible. I never use 100% maintenance because those patients who are critically ill don't need 100% calories. We've measured it at 40, 50, 60. So just know your limitations, know where you stand, know that if you're 10 kilograms, you're going to overdo it. So as you said, if you start 80% restricted in those patients who are 10 kilos, you're not actually restricting them, you're just giving full maintenance anyway. So use the formulas, but just know where their errors are and understand where the limitations are. It's there to stay and it won't change because once things are written in a book, they will never change.
Thank you so much for clarifying on that, Andrew. And over to you now for the next session, for the next talk. Yeah.
Thank you. So it gives me great pleasure to introduce the next session, which is on DKA. And if I can present Dr. Rakshay, who is the head of Pediatric Intensive Care, Rainbow Children's Hospital, Bangalore, president and founder member of Pedi Stars in India, visiting professor at CHOP in America, awarded a fellowship in the point of care ultrasound by the American Academy, has done lots of work on simulation workshops across the country, has lots of publications, and chief areas of interest are point of care simulation and sonography. So welcome, and if you may present your case. Thank you.
Yeah, thank you so much, Andrew, for such a wonderful introduction. It was indeed a great pleasure listening to you, offering wonderful insights on fluid and electrolytes. Easily one of the best talks I've heard on fluid and electrolytes. And I thank Amish and the IAP Mumbai for providing me with this opportunity to talk on decay. I'll just share my slide in a minute. Just 1 second. Second. Yes. Can you all see my slide?
Yeah, it's visible, Rakshay. Yeah.
Thank you so much. So, well, Amish put me in a difficult spot. My talk is almost at the end of the day at around 10 p.m. And also I had to, and the talk is a follow-up to a wonderful talk given by Andrew. It makes the task even more difficult. And on top of it, the talk is on DKA, and the two moderators for the sessions are known for their work in DKA. So it's made even incredibly more hard. So let me just give a perspective about how do we look at the fluid therapy in DKA. And the idea behind DKA talk is not to talk about what are the current available guidelines. And I'm just thinking hopefully next 25 minutes to half an hour, essentially speak about the concepts behind why we do certain things in DKA. And I'll talk about the common anticipated complications in DKA about cerebral edema and AKI. So, fluid is an important topic like what Andrew mentioned, and it's important, I think, to see it as a drug with a very specific indication, a drug with specific composition, a specific dose, and specific side effects. So how do we think using fluid in DKA context, and how do we change the composition where it is indicated? For all those who want to know the nitty-gritties about the fluid therapy per se, in terms of the choice, probably can go to the latest BSPD guidelines, which has been published recently, or even ISPAD guidelines, quite similar in most of the aspects. The current BSPD guidelines, a lot of things are quite similar to ISPAD guidelines. So let's start with one case. So this is a 10-year-old girl presenting with hurried breathing for 10 days, polyuria for 10 days, and altered consciousness for 1 day. Now, on the first day, she goes to an ENT specialist. Now, given cetirizine nasal drops, and the child stays for 7 days at home, and then subsequently goes to a pulmonologist because the child is breathing too fast. Now, the pulmonologist diagnosed this to have LRTI and managed in the hospital. And subsequent next day, the child goes into altered sensorium. And they check the blood sugar, it's 580, and urine ketones is 5 plus, and subsequently gets referred to us. Now, the reason this whole event becomes important is because this is not an uncommon scenario at all. And oftentimes, majority of this first-time diagnosed diabetic ketoacidosis, which we in our country, often gets misdiagnosed. The pediatricians don't see it very often. Oftentimes mistake it as a nasal block, mistake it as pneumonia, and gets the whole detection gets delayed. And in fact, this is probably one of the commonest reasons why we might have a slightly higher incidence of complications, the delayed recognition of the disease itself. Now, when the patient comes to the hospital, is quite unstable. As you can see, the breathing at 60 per minute, acidotic breathing, maintained saturation, blood pressure is 120 by 90, and the sensorium is quite poor. Pupils were slightly unequal, so has hyperventilation and has some CNS dysfunction. So the blood test sent as soon as the child has arrived in the emergency room shows severe acidosis, pH of 6.94, bicarb of 2.6, and base deficit of -30. And what we can also see is a raised creatinine level, and strong iron difference was 33, and strong iron gap was 25. And the serum lactate was in normal range. The serum ketone levels is 5.4. Now, this is again briefly going through the diagnosis of DKA. The current BSPD guidelines, like I said, is quite similar to ISPAD guidelines. The only difference is that they don't focus much on the blood sugar value. But to diagnose diabetic ketoacidosis, one, you need to have hyperglycemia, need not essentially be, but the ISPAD guidelines says that it needs to be more than 200 mg/%. You need to have an acidosis, and that we measure by pH and bicarb. That needs to be either 7.3 or bicarb less than 15. And the reason for that acidosis needs to be ketones. So if you have a facility to measure blood ketones, that blood ketones need to be more than 3 millimoles per liter. So many of the facilities you have, centers might not have a facility to measure blood ketones. So urine ketones becomes an acceptable alternative. But remember one thing, in diabetic ketoacidosis, 75% of the ketones are because of beta hydroxybutyrate. And what we measure in urine ketones is acetoacetate. That's okay for a diagnosis, but might not be very good to identify resolution of DKA. So in case if you don't have blood ketone levels, you could use your urine ketones like this was done before a referral, looking at urine ketones of 5+ to make this diagnosis. So now let's go to a first hour of management of a child who comes to the emergency room. What do we do? Should we be giving an insulin bolus? Because that's something we see very often in a lot of referrals we get. Should we be giving fluid bolus? If yes, how much fluid bolus should we give? Is there a role for soda bicarb bolus? The pH looks extremely less, 6.9. Should we be giving a soda bicarb bolus? So what is commonly stated in most of the guidelines is to give a 10 ml per kg, generally quite slowly over 1 hour. And the reason for this is what happens, a bit of conceptual understanding about why these patients land up in DK is important. Now, for most part, we know the renal threshold for sugar is 180. So if your blood sugar crosses 180, you tend to diurese and you tend to throw out. Now, when you have viral trigger and there is an excessive counter regulatory hormone production in the form of glucagon, adrenaline, and growth hormone, you tend to produce excessive insulin resistance. And that's the tipping point, because one, you have a less insulin, and now you become resistant to that insulin. The blood is full of glucose. Cells don't have any fuel for metabolism, so they alternate fuel, ketones are produced, which gives energy. Now, what happens over time is, because you're throwing up so much of sodium in the urine, you lose a lot of water over days or few days. And then at one point in time, your renal perfusion drops. And the moment the renal perfusion drops, that's the time where the sugar exponentially goes up to 300, 400, 600, 1000 and 1200. The idea behind this giving bolus, a slope of 10 ml per kg over 1 hour, is to restore that renal perfusion. Now, this is very important to understand, because when you do that, when you restore the renal perfusion, again, the patient is going to throw all that sugar down. So just the act of giving a fluid bolus is going to significantly decrease your blood sugar value. And this is extremely important to understand, because you don't need insulin to drop blood sugar. Insulin is something we give to stop ketosis, not to control the blood sugar. So that's conceptual understanding is extremely important. So the idea behind this fluid bolus is not like septic shock or not like a diarrhea, where we give aggressive fluid therapy to replace all the fluid losses. The idea is not to achieve complete euvolemia. The idea is to achieve some restore end organ perfusion. Okay, so that's very important. However, having said that, if a patient does actually present in if the patient does actually present in shock, you might need a bit more fluid bolus than that. But again, the goal of fluid therapy in first hour is not essentially to achieve euvolemia. It is to achieve the end organ perfusion. Okay, so okay, sorry. Okay, so yeah. So this is the whole reason why we don't actually give insulin in the first 1 hour, especially not as a bolus. Even conceptually giving a insulin bolus does not make a sense, because it is it has just a short half-life of 3 to 5 minutes. So even if you start infusion, you would reach this steady state of insulin in a matter of 15 to 20 minutes. So it doesn't really achieve much. And like we just discussed, that giving fluid per se itself is going to drop your sugar. And on top of it, if you push an insulin bolus in your attempt to see that sugar is 900 or 1000 plus to drop the blood sugar, you're going to have a far more sharper drop in the sugar levels. And there is a study in UK cohort which actually showed that giving insulin in first 1 hour increases the risk of cerebral edema. So that's something we never do, is give an insulin bolus in first 1 hour. This is again a study from Desmond Bond from Toronto, and I'll be just talking briefly subsequently, but again goes into the whole concept what Andrew mentioned about maintaining tonicity and osmolality. And it's the whole idea is that during therapy, the drop in sugar should be matched by rise in sodium, and you maintain a steady state tonicity, or it should come down, the osmolality should come down in a much slower fashion. So if you drop it too significantly, then that becomes certainly a risk factor for cerebral edema. So like just to summarize, in the first 1 hour, we give fluid. The fluid is not to achieve euvolemia, but to achieve some decent renal perfusion. Generally, you give 10 ml per kg or 1 hour, and then you would not give insulin in first 1 hour. So what happens beyond first hour? So how do we look fluids? What's the goal of giving a fluid therapy here? So the whole idea behind fluid therapy here, is to adequately rehydrate the patient. At the same time, understand that the fluid therapy has something to do with association of risk factors associated with cerebral edema as well as AKI. And the other aspect is insulin. I would not speak much about insulin therapy in DKA. Okay, so now the biggest difficulty in DKA is identifying the hydration status. It's unlike a diarrhea patient who comes where we do a clinical examination and identify the degree of dehydration, it's not possible in diabetic ketoacidosis, simply because of the fact that these losses are happening over days, not few hours or a couple of days. And coupled with that, you cannot use body weight because of the diabetes itself, there is a lot of muscle loss and lipolysis, and there's a weight loss. So you don't have a significant clinical clue to diagnose what kind of how much percentage of fluid is actually lost by the patient. The current BSPD guidelines gives much more simpler formula, just looking at a bicarb level of 15%, of 15, 10, and 5 to figure out 5%, 7%, 10% dehydration. Now, the way I see a lot of these guidelines are, there's no need to be obsessed with the guidelines. What is important is to have some starting point. The moment you need to know where to start. And once you start, I think then subsequently, how do you titrate your fluid therapy should completely be dependent upon how the patient behaves, rather than just sticking to a protocol all the time. Protocols are very useful, especially in small centers. They're a good starting point, but then you need to know the limitations of the protocols too. So decay is one condition probably where you take one size fit all approach because of the difficulty in clinically assessing them. The general thumb of rule is, majority of those patients need 1.5 times the maintenance up to maximum 2 times the maintenance. That's far more simpler to remember. So what you do is you give a degree of dehydration correction and along with that maintenance, and you correct it over 36 to 48 hours, quite a slow correction. But here, if you're giving 10 ml per kg to achieve renal perfusion, you would deduct that from this calculation. However, if the patient did present in shock and you had to resuscitate with fluid, that is a separate fluid. You would not deduct it from this calculation. So this one calculation I've just shown in the this slide, it's a pretty simple calculation. You could go through those guidelines and understand it better. So now coming to the composition. So there is a lot of concerns about fluid therapy and cerebral edema. So this is a study which was published, the PICARN study, which looked into various composition and percentage of dehydration. It looked into giving normal saline versus half normal saline. And they looked into 36-hour correction versus 48-hour correction. And in this study, they could not find any difference in terms of composition of fluid versus rate of correction. Okay, so in fact, if at all there was any signal, the 36-hour correction had a bit lesser incidence of cerebral edema. So it goes on to show the fact that, it's not about superiority of one protocol or the other protocol. Probably monitoring the patient closely is what is more important. But what we know also is there are probably far more other reasons why patients do develop complications like cerebral edema. Fluid might not be the only reason. However, what we know for sure is if you don't use it judiciously and correctly enough, it can certainly worsen the situation. So now what happens is the initial drop what you're seeing in the in this vertical portion is purely because of fluid bolus. The subsequent drop is because of insulin. Now, if you continue giving insulin, it is going to touch zero at one point in time. So clearly you need to add some dextrose. Now, this is important to understand. The insulin what we give is not to control the blood sugar value at all. The idea is not to cut down the blood your insulin dose purely because the blood sugars are falling down. The idea behind of giving insulin infusion is completely cut off ketosis. So the end point for stopping insulin should be the stopping of ketosis process, okay, not the correction of hyperglycemia. The correction of hyperglycemia generally happens with a combination of both fluid therapy as well as insulin. So like I just said, we give, the sugar falls down and then it dumps, and then the trajectory of insulin happens, the effect of insulin we see. And then, so that's why what's important here is during the whole target, you need to maintain sugar between 150 to 200. It's okay to maintain somewhere up to 200 to 300 range because hypoglycemia is far more problematic than slight hyperglycemia. Occasionally, sugars touching up to 300, 400 is fine. So generally what we try to do is moment the sugar touches close to 300, you add 5% dextrose to the fluid. And then the whole idea is to keep it somewhere between closer to 200. So you might start with 5% dextrose, you might make it to 10% dextrose, you might make it 12.5% dextrose. The general rule of thumb is if you have gone up from 5% to 10% to 12.5%, stick to the same value till the resolutions. Don't go to D10, then come to D5. Don't go to 12.5, then come to D5. It's too much of fluid exchange, too much of changing of fluid, complicates therapy too much. So if you're at 12.5, finish your therapy at 12.5. Okay. And normally we don't cross 12.5 because through the peripheral line, it is not possible to give beyond 12.5. And majority of the patients with this combination of 12.5 and 1.5 to 2 times of fluid what we give, they tend to maintain adequate sugar balance as well as resolution of acidosis. So if your blood sugar does fall less than 150, you can probably increase your fluid rate up to the maximum of 2. And like I said, majority of them would actually resolve their ketoacidosis. So there are a couple more other ways of titrating this. If you can't prepare the fluid in the way, one way is running 2 IV fluid infusions. One is isotonic fluid, other one is isotonic fluid with dextrose, and then you can titrate the dextrose content based upon the blood sugar value. However, to do this, remember that it needs some amount of skill and experience at the nursing level and a physician level, because it needs some amount of calculations and some amount of training. So if you have that expertise, it is a method probably you can use. But in our center, we just prepare solutions, and then we use one solution till the end. Okay, so coming to the insulin dose, in our unit, we use 0.1 units per kg per hour. Probably 0.05 unit per kg per hour is equally effective. The study done in PGI did show that it works quite well. And the reasoning was that majority of children, especially in Indian subcontinent, they do have malnourishment. They are severely hypokalemic too. There's higher incidence of hypoglycemia. However, what we know is a 0.1 works in everybody. 0.05 probably works in the most. So stick to one regimen and go. In our unit, we use 0.1, and we've had good experience with that. And also what we know from this study and this study also, that 0.1 did not lead to much of a complication rate. So 0.1 or 0.05 probably doesn't matter, but there is no point in going beyond 0.1. That's probably the maximum dose you would give in, during correction of decay. So what happens is, during your treatment, moment the fluid rehydration happens, the insulin resistance does come down. So insulin becomes far more effective. And that's the reason we see that the sugar values actually drop down far more quickly. So that's the reason you need to increase your fluid supply as well as the dextrose supply. So the end point of insulin infusion, like I said, it's about resolution of acidosis. You need to get a beta hydroxybutyrate level less than 1. So you can monitor that by looking at the pH. The pH should cross 7.3 with a anion gap less than 14, and sodium serum bicarbonate level should cross more than 15. So what do we do after 4 hours? I mean, lot of guidelines does suggest that you go to half normal saline. The idea behind this is to drop the chloride content given, because a lot of fluids are given. What we do in our unit is we use Plasmolite as a fluid of choice. So we continue that throughout our regimen. So we don't switch from normal saline to half normal saline. We stick to isotonic balanced solutions. We use Plasmolite in our unit, and we just continue that throughout the regimen. We just change the dextrose component of Plasmolite during the therapy. So having said that, I mean, if you have been using half normal saline, you need to be a bit mindful that moment you touch the 4-hour mark, if your serum sodium is particularly low, it might be wiser to just continue with isotonic normal saline. Okay, so let's come to a little bit more of a potassium as well as phosphate concept. And majority of patients do need potassium therapy. And oftentimes fluids are given in the peripheral line. You can go up till 80 millicolons per liter, not more than that. What happens is, though the serum potassium might come high, the total potassium is still low in the body. And the reason why that happens is, in the setting of acidosis, there is exchange of H plus ion versus potassium ion, and the potassium ion gets lost in the urine. So the total potassium does actually fall in the body. So one moment the patient passes urine, and if your serum potassium is not above 4, it's a time to introduce potassium into the fluid mix. So remember, the hypokalemia is still far more safer than hyperkalemia. Hyperkalemia literally kills. And like I said, in a total body potassium is low, and on top of it, adding insulin and resolution of acidosis, they itself worsen hypokalemia. However, again, if you're giving isotonic fluid and then you add potassium chloride to it, the chloride load does actually go up. So a lot of international bodies do suggest adding potassium acetate as a fluid of and potassium phosphate as a way of giving potassium. As far as I know, the potassium acetate is not available, but POT-phos is available in our country. So what we use is a combination of both potassium chloride and POT-phos. So we add around 10 ml of potassium chloride and around 5 ml of POT-phos, because that's a maximum of potassium phosphate you can add in 1 liter from a phosphate point of view. So the amount of potassium you give gets limited with the amount of phosphate we can give in that IV fluid. So phosphorus again is a very interesting thing. So based on some studies done in during the World War on malnourished patients who were kept fasting for a very long period of time, and when they introduced feed, many of them had cardiac arrest and died. That's probably partly similar kind of phenomena can happen sometimes with insulin therapy, especially if serum phosphorus level is less than 0.5. What happens is insulin needs a lot of needs phosphorylation, so does consume a lot of phosphorus, and metabolically active tissue like heart can get depleted of ATP because of less phosphate and can end up in cardiac arrest. So it's important to maintain your phosphorus level. You don't have to take phosphorus level to normal range. As long as you keep it above 1, it should be fine. And this is the reason we add POT-phos into our IV fluid, and it sorts out both the issues of potassium as well as phosphorus. And when you give potassium phosphate, like the way I mentioned, adding 5 ml to around 1 liter of bag, that gives you enough phosphate to maintain phosphorus level in normal range. So you have to continuously monitor using your ECG. Neurological assessment is very important. We'll talk a bit about that. Hourly blood sugar is important. 4-hourly blood gas and electrolytes are important. And beta hydroxybutyrate, if you can measure, you check it every 4 hours. So you would want the blood sugar to fall by 50 to 150 milligram per deciliter every hour. You want pH to go up by 0.03 per hour. You want closing of anion gap. You want serum sodium to rise by 1.6 for every 100 drop in blood sugar. You want a stable corrected sodium, as well as you want a gradual drop in serum osmolarity. So let's come to the most dreaded complication of treatment of decay, that's cerebral edema. Now, why it happens, it's not very clear. Now, there's one concept that's saying it could be because of vasogenic edema, because of inflammation, and then there is altered the blood-brain barrier, and the other concept is about cytotoxic edema, which potentially could be because of treatment-related. So what is interesting though, when you look at the incidence of cerebral edema in decay patients, majority of the cerebral edema, it happens in first hour, and hardly anything happens after 12 hours. So majority of cerebral edema happens within 12 hours. It's very unusual to see beyond that. And what's also interesting to see in this study is that majority of them can have cerebral edema at onset, like we saw in our patient. Now the patient did come with altered sensorium, with unequal pupils, which kind of sorted out later. But that's probably one of the commonest ways cerebral edema presents. And I think especially in Indian context, like I said, the delayed recognition seems to them far more important reason about why they develop cerebral edema rather than the treatment therapy itself. But certainly the treatment regimen, when not done well, can certainly exacerbate the problems. So the studies initially did show that 1% of them do develop cerebral edema of decay patients, of which around 40% develop a very poor outcome in the form of either a poor neurological outcome or death, which means out of 1,000 patients, if you were to see, you're going to have around 10 patients with cerebral edema, of which 4 might have a bad outcome. So the current incidence, the FIS database review, they looked into more than 37,000 DKA patients, and they said the incidence of cerebral edema actually increased to around 4%, but they saw the mortality rate dropped from 40 to 10%. So roughly the poor outcome is roughly the same. It's around 0.45, around 0.4%. So there are initial studies done in early 2000 which looked into what could be the reasons why patients develop cerebral edema with decay. What they came up with these 3 reasons: the high blood urine nitrogen, low CO2, and treatment with bicarb. So if you look at these risk factors carefully, I think they just reflect the degree of acidosis. So clearly, you're going to have a high blood urine nitrogen if you're excessively dehydrated. You're going to have a low CO2 if you're hyperventilating, and you would only treat with bicarb if the pH is very low. So what it goes to say is that the most important determinant for cerebral edema is not about how high the blood sugar value is, not hyperglycemia, but the degree of acidosis, duration of acidosis. And that might be one of the reasons why we sometimes do see patients who get misdiagnosed outside, stay in acidotic state for too long, develop this complication. So I'll just talk a bit about sodium and sodium rise a bit later, but these are the essential concepts, risk factors about why certain patients develop cerebral edema. There's also one more study in the same time looking into the risk factors for cerebral edema and decay. And what they stated was younger patients and those who come with the new onset diabetes, they are at much more higher risk, which is again explainable, like we just discussed, far more delayed recognition. In younger babies, the wet diapers, it's very hard to know polyuria and polydipsia in them. So clearly gets far more delayed in recognition. And all those, like I just mentioned, we see oftentimes patients coming around 8 years, 10 years, staying for many days, being misdiagnosed to upper respiratory tract infection or LRTI, and they do get delayed recognition clearly plays a factor here. So let's understand this bit more about the serum sodium rise and cerebral edema. So now what happens is, moment you have a very high blood sugar value, it has osmotic effect. It draws fluid from the intracellular compartment to extracellular compartment, and with that what happens is sodium drops. So moment we start correcting serum sodium, the sodium correcting blood sugar values with our fluid therapy, what happens then is the osmotic drag becomes much lesser. So the amount of fluid coming out from the intracellular fluid to extracellular fluid drops. So obviously you will see the sodium, measured sodium values going up steadily. So the other way of looking at the same concept is mitigating the effect of blood glucose on sodium. That is what we call as corrected sodium. So what then happens is, if I am going to look at corrected sodium, I'm going to remove the effect of blood sugar. So what we expect then is the corrected sodium should remain normal throughout therapy. If I'm looking at measured sodium, that should rise by like we just discussed, by around 1.6 for every 100 drop in blood glucose, in the blood glucose. So this is one simple formula to look at corrected glucose, where you use this formula like I just said, sodium glucose by 100 divided by 100 into 2. That roughly gives you the corrected sodium. And what's important to understand here is that the corrected sodium should remain normal. So when you monitor though, if you see the corrected sodium is actually dropping or measured sodium is not rising, then that's a cause for concern. Now what is important is that what causes cerebral edema, or is it a reflection of cerebral edema? So many of them believe that it might not actually be causing cerebral edema, but actually might be a result of cerebral edema, because that could be the manifestation of ADH, which basically is saying that brain is actually injured, and that's why the sodium is not actually going up, or is not being maintained, or sodium is actually dropping. So, so what is very important then is, if you see that corrected sodium is dropping or your measured sodium is not rising, look for features for cerebral edema, because that suggests that the brain is actually getting injured, rather than that itself being the reason for brain injury. Okay, so again, it's the same study which I just mentioned that time, run by Dr. Desmond Bond for 6 kids, and what it showed again was, if there's a rapid drop in serum osmolality in the first 4 hours, the chance of cerebral edema becomes far more higher. So how do we recognize cerebral edema then? Now, some of those things are very simple and straightforward: being unresponsive to pain, respiratory pattern, posturing, cranial nerve palsies. But what is interesting here in the major criteria is incontinence. That is something we can watch at the bedside, especially in a teenage patient, adolescent patient group. And if they're not catheterized, and if they're passing urine in the bed, look for features of raised ICP, because that again is a marker for cerebral edema. Rest of things like heart rate and heart mentation are quite self-explanatory. So is there a role for head CT? Now head CT for most patients, it's not really required. You don't need that to diagnose, because if the patient has all those clinical features and the CT comes normal, you still have to treat cerebral edema. But if you see mild cerebral edema and patient does not have any of those features, then you might not be actually treating with the osmotic therapy. Now, with the heart augmentation though, there are a couple of things I would want to tell you, because patients oftentimes are drowsy. That should not be taken as altered sensorium, right? So it's important to talk to them, ask them what their name is, where they are, which day it is. And if they're able to answer those questions correctly, despite being drowsy, it's very unlikely they have cerebral edema. Okay, so that's important. And also, when we talk about hypertension and cold peripheries, majority of DKA patients tend to be hypertensive and have cold peripheries. Again, that should not be mistaken as cerebral edema, and then give mannitol or 3% saline. So look for incontinence, ask appropriate questions, assess sensorium correctly. Just because they're drowsy, don't assume they have cerebral edema, and don't jump just because there is hypertension, and then treat with osmotic therapy. Okay. All right. So how do we treat cerebral edema? So there is this large retrospective study which was published by the Boston group, which looked into hypertonic saline versus mannitol. So this is a retrospective study, and what they noticed was, the initial part of 2000, a lot of people were using mannitol, and by around 2007, the use of 3% saline went up, and there were and then they compared these two groups to see what happens between 3 groups: mannitol alone, hypertonic saline alone, and combination of these three. And what they found was the treatment with hypertonic saline had a higher risk towards a poor outcome. So they said the mortality rate was slightly more when they actually used hypertonic saline compared to mannitol. So that might so that's one of the reasons why we use mannitol in our unit. Mannitol is a you just give out 15 minutes. So there's a slight pointer to say that it might actually be better than hypertonic saline in patients who develop cerebral edema because of diabetic ketoacidosis. If you don't have access to mannitol or don't store any longer, 3% saline is an acceptable alternative. However, again, given our 15 minutes, you need to be very careful about not giving it too much. You can stop the infusion immediately once the sensorium improves better, because you don't want too much of sodium shift and then have complications like cerebral point and malanalysis. I'll just come with last couple of slides of mine, and that's to do with AKI. So we spoke a lot about sodium and how it affects cerebral edema. We heard a talk by PGI team about how sodium is so important when it comes to brain. So we can think about chloride in your fluid with regards to kidney. Okay, so Dr. Andrew said that it has no effect on mortality. However, there is some amount of association. We don't know whether it's a cause or a result with the renal dysfunction. So this study, again published from US, published in JAMA, said that roughly around 62% of people do develop AKI, and surprisingly around 20% of them land up having a stage 3 AKI. Again, a PGI study done, the SPING trial, also showed around 54.5% of AKI in Indian patients, children who present with DKA. So this again a study done by Mulai Balaji from PGI, and what he showed in his study was that at the end of 24, if there is hyperchloremia, that had an independent association with AKI. There was a subsequent study done by Vijay Williams, again from PGI, and they looked into using plasma light, the balanced salt solution, in first 4 hours of therapy. And what they wanted to see if there was any incidence of higher incidence of AKI, poor resolution of AKI, or use of CRRT. They could not find any difference. So they did not find a difference in resolution of AKI, time to resolution of decay, need for RRT, mortality, or duration of PI stay, the PQ stay. Just to reiterate the fact, just to complete the whole story and journey of this patient, I'll just quickly go through about how the management happened over a couple of days. So like the patient received 10 ml per kg of normal insulin bolus. Remember, the patient did not receive insulin bolus at that point in time. Oxygen was started. The blood gas was quite bad. Like we just saw, the pH was serum blood ketone levels was 6.4, pH was just 6.8, bicarb was 2. So patient was given 10% dehydration correction. Because the sensorium was poor and there were pupillary inequalities, the patient received mannitol. CT scan thankfully was normal. Subsequently, 0.1 unit per kg per hour of insulin infusion was started. This is how the sugar steadily came down from 500 to 200. And the acidosis part improved, but what we saw was the bicarb was stuck at 2.7, 2.1, and 3.1. Base deficit did not fluctuate much. The ketosis was, however, coming down steadily from 6.4 to 4.8, and the sensorium was getting gradually better over time. What also, this is again looking into the pH, as we can see the pH, bicarb and base deficit, pH improved, but the bicarb and the base deficit part were kind of stuck. And when we looked at corrected sodium, what we can see is the corrected sodium was around 150s and stayed there throughout therapy. What we saw is the chloride level went from 114 to 132. And if you look at the anion gap, the anion gap did actually reduce from 25 to 50. So this clearly tells us that the ketosis was actually reducing, but then there is hyperchloremic metabolic acidosis, or normal anion gap acidosis, or normal sick acidosis was actually reappearing. So what we did in this patient was, though the patient got better, but there was persistent metabolic acidosis as well as some impaired renal functions. What we decided to do was not to start bicarb fluid, but to start chloride-free fluids with the idea of giving chloride-free formula to correct hyperchloremia, and that actually improved the pH. The bicarb went from 6 to 12.4. Base deficit actually came down from 20 to 9.5. Anion gap also reduced. And then the patient over next 24 hours, sugars actually dropped. We had to increase the IV fluid from 5% to 10%. We finished off correction at around 10%. The ketosis also resolved from 4.8 to 1.4, and subsequently sensorium also was quite good, and the patient was transitioned to subcutaneous insulin. So with that, I'm going to conclude this talk. I think what's important for us to go home message is that avoid giving insulin bolus in first 1 hour or starting insulin infusion in first 1 hour. Aggressive fluid resuscitation is probably not required in first hour. the idea is to just achieve end organ perfusion. Don't use soda bicarb fluid to correct acidosis during the decay correction. Isotonic fluids are the fluid of choice and certainly should be needed in first 4 hours, and can be used to correct the fluid correction over 36 to 48 hours. So you have to use increase in dextrose concentration till the acidosis gets resolved to keep blood gas around 200. And don't keep decreasing your insulin infusion rates purely because the sugar is falling. The endpoint to start insulin infusion is correction of acidosis, but not hyperglycemia. Look for NN gap. This is very important because you might keep on thinking that acidosis is not getting better, DK is not getting better, but in fact, you might be developing hyperchloric metabolic acidosis, and that does not get corrected by insulin therapy. Insulin therapy only corrects ketoacidosis. It would not correct normal NN gap acidosis. So majority of cerebral edema do happen in first 6 hours, 6 to 12 hours. And corrected sodium, if it is dropping, it could be a sign of a brain injury. Incontinence during treatment could be a sign of cerebral edema. Head CT has a very limited role. Mannitol would be a preferred choice to treat the cerebral edema. And balanced salt solution is a one way of looking into fluid therapy if you want to avoid hyperchloremia during treatment, and a possible strategy for management of decay. So with that, I just conclude my talk. Thank you very much for patient listening.
Excellent talk, Arakshay. It's gone very well. Andrew, any comments? Anyone else have any comments before we take up the questions?
Yeah,
Okay.
I can just say 2 comments. First of all, excellent talk. Really, you covered a huge amount of ground, and I'm glad there's common ground. Just 2 points, really. Number one, on AKI, it's a bugbear of mine that people talk about renal injury, but never talk about what factors are behind it. And in DKA, when we researched it, we found actually AKI was associated with myoglobinuria and rhabdomyolysis. So, in fact, in all patients where the kidneys went off, you would find rhabdomyolysis from teenagers lying unconscious in a room, cold, hypothermic, etc. So that became important to find the cause of AKI. A standard DKA should not have AKI. So if things are going well, there's something else going on. The second is just on chloride, is to start doing chloride ratios, to look at that, because if you don't give therapy and you let the patient fix themselves, they will fix themselves. So I know you're giving a balanced solution, but if you actually don't give anything, they fix themselves as well. So I think there's a lot of understanding in terms of physiology, etc. But the most important point is, which you said, it doesn't matter what the guideline is, monitor the patient. The ketones must come down. And if the ketones come down and you are closely monitoring the patient, whatever fluids you use, whatever your strategy is, the patient's going to get better because you're there looking at them. So that's the gold message, which was superb. Thank you.
Rakshay, one thing, or Andrew, so what you said about the AKI with myoglobinuria. So what we have found out around a few patients was having severe hypophosphatemia. And then one of the reasons for the myoglobin injury or myoglobinuria was severe, those patients with DK with hypophosphatemia had myoglobinuria and AKI. So have we looked into the phosphate level and the AKI?
Yes, so we don't chase phosphate, because the minute you start chasing phosphate, you mess calcium up. The minute you mess calcium up, you start damaging the kidneys more. So there's I could talk for hours on DKA. I've spent most of my life on it. It's so complicated, but I think that's a valid point. Really valid point.
If you have too low hypophosphatemia, that one of the reasons for your myoglobin injury or myoglobinuria. So should we correct for a certain level and then stop chasing the phosphate?
The actual commonest mechanism of rhabdomyolysis is not phosphate, is actually hypothermia. And it happens for some reason in teenagers. So they become unconscious. No one is quite monitoring them. And they lie sort of in a bed on a muscle mass, because you need muscle injury. And so the commonest mechanism we actually found is teenagers who became unconscious. They didn't take the insulin because they're rebelling against the family or whatever. And they would actually have muscle injury from lying on their muscles. So, I wouldn't leap into phosphate as the sole cause of rhabdomyolysis. It's more complicated, but one needs to look at it and start looking at different mechanisms. Just the other one comment, actually, if I can say, I don't trust any American database, as some of the papers said on mannitol. That paper is referencing a huge medical insurance database where there is no screening of what patients are in there, and they said mannitol is good for you, hypertonic saline is not. My problem is this: I don't want to give an osmol diuretic that makes you pee more because polyuria is there. I want to know what my sodium is because my corrected sodium is key, and mannitol interferes with corrected sodium. And I don't want to give an osmotic load to my kidney when I know it might be suffering, because I wouldn't give mannitol in acute kidney injury. So for those reasons, we pushed very hard in the UK guideline to have the option of hypertonic saline. You don't have to use it. You can use whatever you like, but I like to use something that I know I'm adding it up and I know I can follow that, because so it's just, it's whatever you use, be meticulous, but there are lots of options.
Can I ask you one question, Andrew? I mean, this is with regards to the sodium itself. So one of the concerns raised about using isotonic fluids is its effect on fluid balance. So some proponents say that the positive fluid balance is shown to have a poor outcome by around 48 hours in many of the critical illnesses. And using isotonic fluid, even it tends to retain more fluids and they tend to become more positive fluid balance by around 48 hours. And it might actually lead to a poor outcome, especially conditions like ARDS. So what are your thoughts on that? I mean, does it, in terms of fluid balance, does it have an effect?
Yeah, so I can tell you now, because we saw all the worst of DKAs where people didn't know what to do, and this was 20 years ago when the UK guidelines were terrible, and we battled to change them. Our approach was extremely aggressive. We said the patient is going to fix themselves. Just let them fix themselves. Keep the patient awake. So the minute the patient is drowsy, they must have cerebral edema, give them 3%. And so what we did is, and we measured the ketones, blood ketones. Ketones must come down in 8 hours. So virtually, if you follow the right amount of insulin, restrict them like crazy, because they are all actually hypertensive. Majority of DKAs are hypertensive. They're not volume depleted. As you said, they don't need volume. We gave them no maintenance fluid. We restricted them to about 50%. We watched them in 8 hours, gave them hypertonic saline. We've published papers on that, like Des Bones. 8 hours later, the ketones are gone. They are hypochloremic. Let them drink. They will fix their hypochloremia, because the risk of DKA is gone in terms of the cerebral edema, because that was the early phase. And literally, I mean, we had over 100 where we followed that process. They got better, the corrected sodiums come up, and the problem was solved. The problem is I had to go to a guideline group like the BPSD, which is evidence-based, and I took the extreme view, knowing that we would end up in the middle. So I actually said, we're going to restrict them like crazy to the point of dehydration. And they said, you're crazy. And then they came at 120 per kilo, and we met in the middle. And that's where the UK guidelines are. Meet in the middle, but don't let them become drowsy on you, because then, and that's a mistake. I don't care about acid base and acidosis. I care about the ketones coming down, because when they came down, you're winning. So that was our philosophy. Really, really simple. Just don't give them too much fluid. Get them over the first 8 hours. Once you're there, they will drink, they will sort themselves out. So that was our approach. Just very, very simple.
So excellent. I think we had a feast of a lot of talks. I think lots of questions were there, but which Rakshay and Andrew covered in their comments, and how to give low chloride fluids and how to give. One thing was, what sometimes can we give more insulin above 0.1 if the child is not responding?
Yeah, so I think I just tried to respond to that question. So we can hear from Dr. Jeshla and from Dr. Andrew too. So the point is that's the whole study in the PGA, right? So they try to actually come down on insulin rather than going up. And oftentimes, if you're beyond 0.1, if you're not responding, then you need to look into the preparation, because many times, whether it's an expert preparation, whether the insulin is actually not primed enough, is it attached to the tubings, How is your delivery? You need to look into those kind of questions about why it is not working rather than actually increasing efficiency 7.1.
My view is quite simple. If the ketones are not coming down, beta hydroxybutyrate, you have to go up on insulin because it's the only thing that's going to work. They are a very small percentage of teenagers who are insulin resistant because they've had all sorts of stuff and antibodies and whatever through life. Occasionally, they'll need 0.2, and you just watch your ketones. If your ketones are not coming down, which come down in 95% of DKAs hour on hour, you're winning. And as I agree with you, 0.1 gets you there. If you want to use 0.05, fine. Just make sure they come down. So very rarely you will need higher doses, but that tends to be alcoholics. So if you have alcoholic liver disease, your ketone clearance is completely messed up because of the beta hydroxybutyrate in the kidney. They will need if you have teenage alcoholics, which is a problem somewhere. So those are exactly that. Look for those little things. I could talk all day on DKA, so maybe sometime we'll talk. So really thoroughly enjoyed this. So it's been great to talk to everyone.
Same, yeah. Minaj Sheikh, Dr.
Yeah.
Sheikh, yeah.
Yeah, it's 11 midnight now. So we had the luxury and honor to have the people, the best of mind around with us. We sincerely thank them all. I won't name, they have been excellent. Thanks to our moderator, thanks to our attendees. They have been in a good number. And our organizing team, including our president, Dr. Parmanand, Secretary Dr. Amish, our Joint Secretary Dr. Lakshmi, and entire OB member of Intensive Care Chapter of Mumbai IAP. I have seen a couple of seniors who have been with us, Dr. Buche, Dr. Maru Sundaram, Dr. Sunil Vaidya. They have been they have been quite senior in their field, and they are there till now. So I think everyone did exceptionally well. And we stop over here. We sincerely thank all, including our technical support, Bhavik. You have been exceptionally helpful to us in arranging all these things, technical background. And we'll meet tomorrow again at 8:30, same time, same platform. Thank you. Good night.
Thank you, everyone.
Thank you. Thank you.
Thank you very much.
Thank you. Thank you. See you tomorrow again.
Thanks a lot.
Thank you, madam.
Thank you, madam.
Good night. Thank you. Good night. Good night.
Good night.